Greetings to one and all. On behalf of Dr. Kumar Prabhash and Onconxt, I warmly welcome you all to case simulation. First, I'll give you a brief introduction to case simulations. The purpose of this meeting is to bridge the practice gap. The participants are requested to navigate through three cases before 6 p.m., followed by which the expert panel will once again dissect the same case and bring out final nuance to manage the same case. We request all participants to attend the pre-meeting case simulation by clicking on the link above the chat box. Please finish the case simulation before 6 p.m. The case simulation has 6 steps and we request you to finish all the steps. The outcomes of participants' case simulation will be presented during the live panel discussion. Once you click on the link, this page will be displayed where you have to fill up these following details and click on the tab Next. Log in with your registered email ID to watch the webinar. Then you have to click on the tab Participate in Pre-Meeting Case Simulation. A page will be displayed where a case of eminent faculties will be present. Then you have to click on tab Start Case. First, there is an introduction part which contains the subjective data and case history. Then click on the tab Next. It contains all the investigational data which includes examination, lab parameters, imaging, and cytology and histochemistry and molecular test. Click on this tab to get more insights. Click here to view the scan image. In order to zoom the image, click here. Then click on the tab Next. In order to create a case summary, fill this following details. Then click on the tab Save and Next. Then click on the what are the various criteria for treatment selection. Please select the options and click on the arrow button to set your order of priority, 1 for the most important and 10 for the least important. Then click on the tab Submit and Next. Select the best 2 treatment strategy. Please select the best 2 treatment strategy from table 1 and table 2. The points which are marked in blue. Then click on the tab Submit. Then rank the treatment regimen. For each regimen select earlier, please give score to each of the 6 parameters. 5 is equal to good and 1 is equal to poor. Click here to see the comparison. A graphical representation will be there. This is the last slide. In order to move to the next case, press on Go to Next Case. Thank you. See you all sharp at 6 p.m. for the live panel discussion by all the eminent faculties. Greetings to one and all. On behalf of Dr. Kumar Prabhash and Onconxt, I warmly welcome you all to case simulation. First, I'll give you a brief introduction to case simulations. The purpose of this meeting is to bridge the practice gap. The participants are requested to navigate through three cases before 6 p.m., followed by which the expert panel will once again dissect the same case and bring out final nuance to manage the same case. We request all participants to attend the pre-meeting case simulation by clicking on the link above the chat box. Please finish the case simulation before 6 p.m. The case simulation has 6 steps and we request you to finish all the steps. The outcomes of participants' case simulation will be presented during the live panel discussion. Once you click on the link, this page will be displayed where you have to fill up these following details and click on the tab Next. Log in with your registered email ID to watch the webinar. Then you have to click on the tab Participate in Pre-Meeting Case Simulation. A page will be displayed where a case of eminent faculties will be present. Then you have to click on tab Start Case. First, there is an introduction part which contains the subjective data and case history. Then click on the tab Next. It contains all the investigational data which includes examination, lab parameters, imaging, and cytology and histochemistry and molecular test. Click on this tab to get more insights. Click here to view the scan image. In order to zoom the image, click here. Then click on the tab Next. In order to create a case summary, fill this following details. Then click on the tab Save and Next. Then click on the what are the various criteria for treatment selection. Please select the options and click on the arrow button to set your order of priority, 1 for the most important and 10 for the least important. Then click on the tab Submit and Next. Select the best two treatment strategy. Please select the best two treatment strategy from table 1 and table 2. The points which are marked in blue. Then click on the tab Submit. Then rank the treatment regimen. For each regimen select earlier, please give score to each of the 6 parameters. 5 is equal to good and 1 is equal to poor. Click here to see the comparison. A graphical representation will be there. This is the last slide. In order to move to the next case, press on Go to Next Case. Thank you. See you all sharp at 6 p.m. for the live panel discussion by all the eminent faculties. Greetings to one and all. On behalf of Dr. Kumar Prabhash and Onconxt, I warmly welcome you all to case simulation. First, I'll give you a brief introduction to case simulations. The purpose of this meeting is to bridge the practice gap. The participants are requested to navigate through three cases before 6 p.m., followed by which the expert panel will once again dissect the same case and bring out final nuance to manage the same case. We request all participants to attend the pre-meeting case simulation by clicking on the link above the chat box. Please finish the case simulation before 6 p.m. The case simulation has 6 steps and we request you to finish all the steps. The outcomes of participants' case simulation will be presented during the live panel discussion. Once you click on the link, this page will be displayed where you have to fill up these following details and click on the tab Next. Log in with your registered email ID to watch the webinar. Then you have to click on the tab Participate in Pre-Meeting Case Simulation. A page will be displayed where a case of eminent faculties will be present. Then you have to click on tab Start Case. First, there is an introduction part which contains the subjective data and case history. Then click on the tab Next. It contains all the investigational data which includes examination, lab parameters, imaging, and cytology and histochemistry and molecular test. Click on this tab to get more insights. Click here to view the scan image. In order to zoom the image, click here. Then click on the tab Next. In order to create a case summary, fill this following details. Then click on the tab Save and Next. Then click on the what are the various criteria for treatment selection. And click on the arrow button to set your order of priority, 1 for the most important and 10 for the least important. Then click on the tab Submit and Next. Select the best two treatment strategy. Please select the best two treatment strategy from table 1 and table 2. The points which are marked in blue. Then click on the tab Submit. Then rank the treatment regimen. For each regimen select earlier, please give score to each of the 6 parameters. 5 is equal to good and 1 is equal to poor. Click here to see the comparison. A graphical representation will be there. This is the last slide. In order to move to the next case, press on Go to Next Case. Thank you. See you all sharp at 6 p.m. for the live panel discussion by all the eminent faculties. Greetings to one and all. On behalf of Dr. Kumar Prabhash and Onconxt, I warmly welcome you all to case simulation. First, I'll give you a brief introduction to case simulations. The purpose of this meeting is to bridge the practice gap. The participants are requested to navigate through three cases before 6 p.m., followed by which the expert panel will once again dissect the same case and bring out final nuance to manage the same case. We request all participants to attend the pre-meeting case simulation by clicking on the link above the chat box. Please finish the case simulation before 6 p.m. The case simulation has 6 steps and we request you to finish all the steps. The outcomes of participants' case simulation will be presented during the live panel discussion. Once you click on the link, this page will be displayed where you have to fill up these following details and click on the tab Next. Log in with your registered email ID to watch the webinar. Then you have to click on the tab Participate in Pre-Meeting Case Simulation. A page will be displayed where a case of eminent faculties will be present. Then you have to click on tab Start Case. First, there is an introduction part which contains the subjective data and case history. Then click on the tab Next. It contains all the investigational data which includes examination, lab parameters, imaging, and cytology and histochemistry and molecular test. Click on this tab to get more insights. Click here to view the scan image. In order to zoom the image, click here. Then click on the tab Next. In order to create a case summary, fill this following details. Then click on the tab Save and Next. Then click on the what are the various criteria for treatment selection. Please select the options and click on the arrow button to set your order of priority, 1 for the most important and 10 for the least important. Then click on the tab Submit and Next. Select the best 2 treatment strategy. Please select the best 2 treatment strategy from table 1 and table 2. The points which are marked in blue. Then click on the tab Submit. Then rank the treatment regimen. For each regimen select earlier, please give score to each of the 6 parameters. 5 is equal to good and 1 is equal to poor. Click here to see the comparison. A graphical representation will be there. This is the last slide. In order to move to the next case, press on Go to Next Case. Thank you. See you all sharp at 6 p.m. Greetings to one and all. On behalf of Dr. Kumar Prabhash and Onconxt, I warmly welcome you all to case simulation. First, I'll give you a brief introduction to case simulations. The purpose of this meeting is to bridge the practice gap. The participants are requested to navigate through three cases before 6 p.m., followed by which the expert panel will once again dissect the same case and bring out final nuance to manage the same case. We request all participants to attend the pre-meeting case simulation by clicking on the link above the chat box. Please finish the case simulation before 6 p.m. The case simulation has 6 steps and we request you to finish all the steps. The outcomes of participants' case simulation will be presented during the live panel discussion. Once you click on the link, this page will be displayed where you have to fill up these following details and click on the tab Next. Log in with your registered email ID to watch the webinar. Then you have to click on the tab Participate in Pre-Meeting Case Simulation. A page will be displayed where a case of eminent faculties will be present. Then you have to click on tab Start Case. First, there is an introduction part which contains the subjective data and case history. Then click on the tab Next. It contains all the investigational data which includes examination, lab parameters, imaging, and cytology and histochemistry and molecular test. Click on this tab to get more insights. Click here to view the scan image. In order to zoom the image, click here. Then click on the tab Next. In order to create a case summary, fill this following details. Then click on the tab Save and Next. Then click on the what are the various criteria for treatment selection. Please select the options and click on the arrow button to set your order of priority, 1 for the most important and 10 for the least important. Then click on the tab Submit and Next. Select the best 2 treatment strategy. Please select the best 2 treatment strategy from table 1 and table 2. The points which are marked in blue. Then click on the tab Submit. Then rank the treatment regimen. For each regimen select earlier, please give score to each of the 6 parameters. 5 is equal to good and 1 is equal to poor. Click here to see the comparison. A graphical representation will be there. This is the last slide. In order to move to the next case, press on Go to Next Case. Thank you. See you all sharp at 6 p.m. for the live panel discussion by all the eminent faculties. Greetings to one and all. On behalf of Dr. Kumar Prabhash and Onconxt, I warmly welcome you all to case simulation. First, I'll give you a brief introduction to case simulations. The purpose of this meeting is to bridge the practice gap. The participants are requested to navigate through three cases before 6 p.m., followed by which the expert panel will once again dissect the same case and bring out final nuance to manage the same case. We request all participants to attend the pre-meeting case simulation by clicking on the link above the chat box. Please finish the case simulation before 6 p.m. The case simulation has 6 steps and we request you to finish all the steps. The outcomes of participants' case simulation will be presented during the live panel discussion. Once you click on the link, this page will be displayed where you have to fill up these following details and click on the tab Next. Log in with your registered email ID to watch the webinar. Then you have to click on the tab Participate in Pre-Meeting Case Simulation. A page will be displayed where a case of eminent faculties will be present. Then you have to click on tab Start Case. First, there is an introduction part which contains the subjective data and case history. Then click on the tab Next. It contains all the investigational data which includes examination, lab parameters, imaging, and cytology and histochemistry and molecular test. Click on this tab to get more insights. Click here to view the scan image. In order to zoom the image, click here. Then click on the tab Next. In order to create a case summary, fill this following details. Then click on the tab Save and Next. Then click on the what are the various criteria for treatment selection. Please select the options and click on the arrow button to set your order of priority, 1 for the most important and 10 for the least important. Then click on the tab Submit and Next. Select the best 2 treatment strategy. Please select the best 2 treatment strategy from table 1 and table 2. The points which are marked in blue. Then click on the tab Submit. Then rank the treatment regimen. For each regimen select earlier, please give score to each of the 6 parameters. 5 is equal to good and 1 is equal to poor. Click here to see the comparison. A graphical representation will be there. This is the last slide. In order to move to the next case, press on Go to Next Case. Thank you. See you all sharp at 6 p.m. for the live panel discussion by all the eminent faculties. Greetings to one and all. On behalf of Dr. Kumar Prabhash and Onconxt, I warmly welcome you all to case simulation. First, I'll give you a brief introduction to case simulations. The purpose of this meeting is to bridge the practice gap. The participants are requested to navigate through three cases before 6 p.m., followed by which the expert panel will once again dissect the same case and bring out final nuance to manage the same case. We request all participants to attend the pre-meeting case simulation by clicking on the link above the chat box. Please finish the case simulation before 6 p.m. The case simulation has 6 steps and we request you to finish all the steps. The outcomes of participants' case simulation will be presented during the live panel discussion. Once you click on the link, this page will be displayed where you have to fill up these following details and click on the tab Next. Log in with your registered email ID to watch the webinar. Then you have to click on the tab Participate in Pre-Meeting Case Simulation. A page will be displayed where a case of eminent faculties will be present. Then you have to click on tab Start Case. First, there is an introduction part which contains the subjective data and case history. Then click on the tab Next. It contains all the investigational data which includes examination, lab parameters, imaging, and cytology and histochemistry and molecular test. Click on this tab to get more insights. Click here to view the scan image. In order to zoom the image, click here. Then click on the tab Next. In order to create a case summary, fill these following details. Then click on the tab Save and Next. Then click on the what are the various criteria for treatment selection. Please select the options and click on the arrow button to set your order of priority, 1 for the most important and 10 for the least important. Then click on the tab Submit and Next. Select the best 2 treatment strategy. Please select the best 2 treatment strategy from table 1 and table 2. The points which are marked in blue. Then click on the tab Submit. Then rank the treatment regimen. For each regimen select earlier, please give score to each of the 6 parameters. 5 is equal to good and 1 is equal to poor. Click here to see the comparison. A graphical representation will be there. This is the last slide. In order to move to the next case, press on Go to Next Case. Thank you. See you all sharp at 6 p.m. for the live panel discussion by all the eminent faculties. First and foremost, I'd like to thank all the participants for participating in case simulation. Now I'd like to invite Dr. Kumar Prabhash sir for the introduction.
Hi, no, thank you for this opportunity. Idea for this meeting has been to develop some newer module and newer way of communication, and let's how it turns out to be when we have this meeting. Uh, what we have tried to do is have certain concepts in lung cancer, which is important, and try to communicate to the audience in a beyond the usual way, and we will see those things as it rolls out. So with this, I welcome all and hand back the to the organizers.
Thank you, Dr. Kumar Prabhash sir, for the wonderful introduction. Now I'd like to invite our first chairperson, Dr. Colonel VP Singh, Senior Advisor, Surgery and Surgical Oncologist at Command Hospital, Kolkata. Over to you, sir.
Thank you. Thanks a lot, Dr. Kumar Pravash sir and his team, to give me this opportunity to chair a session in Meet. Not taking much of time. Now I'd like to invite our first speaker, Dr. Anuradha Chogle. Dr. Anuradha Chogle, madam, is Professor and Scientific Officer in Medical Oncology and Molecular Lab at TMH, and she's a big name in her field. I wish all the very best to her and hand over to her, Dr. Anuradha Chogle.
Yeah, thank you so much for the very warm introduction. I would like to share my slides without wasting much time. Yeah. Can you see the screen?
Yes, ma'am, we can see your screen.
Yeah, ma'am, it's nicely visible, ma'am.
Ma'am, can you make it full screen?
Yeah, sure. Yeah. So thank you, organizers, for giving me this opportunity. And today's topic is mainly on the molecular testing in NSCLC, guidance for modern patient-centered precision lung cancer care. So what are the essential guidance we need to follow while doing the molecular testing, especially in the molecular lab and in this era of precision medicine, and especially on the next generation sequencing, because we have marched past from single gene testing to multiplex testing on the next generation sequencing, because it is just not the EGFR which we need to look upon, but there are various molecular alterations where we get to have the therapies at the when we target them on the next generation sequencing. So these are the because there are a lot of suboptimal testing rates have been happening, and we need to see how can we overcome these existing unmet needs, and what are the barriers to broad-based implementation of genomic testing in lung cancer. So I'll just give an overview how it is to be performed in the laboratory thing. So here you get to see a big landscape of which are the mutations other than EGFR which has to be looked upon. So it's you get to see the KRAS mutation about 25%, and HER2 mutation around 1%, ALK rearrangement, ROS1 MET mutation amplification, as well as the MET exon 14 skipping. And also you get to see the BRAF mutation and the NTRK rearrangement. And there are various targeted therapies, as you can see over here, where you have these therapies against this driver actionable mutations. So let us go ahead with this. Like, what are the molecular testing standard of care when we get to see the patients with the advanced NSCLC? So histologically, whether when it is a non-squamous histology or the squamous lung cancer. So in the non-squamous, that is in the adenocarcinoma, primarily we need to do the testing for the EGFR, ALK, ROS1, PRAF, and the PRAF testing. If it is a squamous, of course, for the non-smokers only we are looking for the EGFR testing, but it's not so right. At present, we get to see the EGFR in the smokers as well. So we have to do the testing for all the whether it is a squamous or the non-squamous one. When the patient goes into the resistant with the against the sensitizing mutation, we look for at the progression, we look for the EGFR T790 mutation. Other than this, we recommend testing now for, as you have seen in the previous slide, there are 2 to 1% of various these rearrangements are present. So it has also been recommended for the MET, RET, ERBB2, NTRK, and the RAS and TP53 gene. So this is a whole how it has been the time. Upon it. So, which molecular alterations need to be investigated first, as I showed in my previous slide. So, it is the EGFR, RET now has been included. These are the FDA-approved therapies. So, MET exon 14 skipping, which is a new one, targeted therapy has been available. So, and other than that, all cross1, BRAF, 600E, and TRK. And the emerging targets are now the KRAS, G12C, and the HER2 thing. So what are the precision medicine strategies in the NSCLC? Let us look upon that. So if you have a EGFR mutated platinum doublet or the pemetrexed preferred. But if you get then coming to the clinical or the radiologic progression, as you can see over here, that is the T790 mutation testing is done, and if it is positive, the osimertinib is administered, and if it is negative, again the same chemotherapy algorithm is followed. But if you come to see again with the platinum base, you get to if it is progression, docetaxel is given, and the clinical or the radiologic progression, again we can consider for the PDL1 testing. Again, it can be based on either tumor molecular burden, or if you get to see do the IHC, which is the best very cost effective test, we can also administer with the PDL1 more than 50% positive. We can administer for the pembrolizumab or nivolumab for the testing is there, which is an FDA approved, which is done by the Quagen. And but again, it is done on the FFP tumor tissue, and the therapy available is of the afatinib or gefitinib, which has a turnaround time of 7 days. So Foundation Medicine, yes, they have come up with the on the NGS platform, and they have around 300 panel gene, and you can with the molecular alterations present, you can treat them with the various afatinib too. You can see the debrafenib, and also the trametinib is present. And but the NGS turnaround time is around 10 to 14 days. So these are the various platforms which are available for the to detect the various biomarker for the NSCLC. And here you can see on the also the Oncoman DX target, which is again an FDA approved on the, which is the Thermo Fisher based on the NGS platform. So who needs to be tested? The disease, as the disease stages, only the test patients with advanced stage 4 disease. No, it is not the case now. We need to look also for the stage 1 and stage 2, where the EGFR we are getting at a very low percentage positive. Age wise, only test younger patients. No, it is also done at across all the age wise disease. Histology, only test adenocarcinoma. No, it is, as I said in the previous, we need to look for the squamous cell carcinomas as well for the testing. Smoking history, only testing non-smokers. No, because we have also found out the EGFR mutation in the smokers as well. So what are the histologies which need to be tested? So metastatic non-squamous NSCLC, absolute standard of care test for every patient. Adenosquamous NSCLC, we need to test for again for every patient. Test all non-smokers and light smokers with squamous and small cell histologies as well. Genetic alterations are found in squamous NSCLC with the NGS platform. So the targetable mutations are also found in the sarcomatoid carcinomas as well. So also we need to take them for the EGFR testing or for the various biomarker alterations. So NGS conducted on tumors of 7 patients. Here is a data where they could see the 136 putative somatic variants and 1 gene fusions were identified. But 16 variants were considered as a hotspot mutation, as you can see, EGFR, EML for ALK, MET, BRAF, PIK3CA, and TP53. So this EML for ALK fusion and the EGFR exon 19 deletion were confirmed on the Ventana IC. So the molecular targeted therapy may be useful treatment strategy for the PSC with targetable alterations. So again, with the prevalence of MET exon 14 skipping, what we are seeing it now, were investigated, and these are again 4 patients were found, that is around 9%. So we can treat this patient now because of the available targeted therapy. So the targeted therapy is potentially moving to early stage 2 NSL. Should we be testing earlier? As with the, you can see with this ADURA phase 3 trial, yes, with the stage 1B, 2, 3A AGF with the EGFR mutation positive, with complete tumor resection optional, standard of post-operative adjuvant along with the adjuvant chemotherapy, and in the experimental arm, it can be patients were treated with osimertinib for 3 years. So coming to the young and old smokers, as I mentioned earlier, yes, we have to do the testing for young and old smokers and non-smokers. All need to be tested, because in this trial of this, you can see EGFR mutation, ALK rearrangement, ROS1 arrangements, HER2 exon 20 insertions were more common among young patients, and frequency was steadily decreased with the age. So it's right.
Sorry for the technical glitch. I think so, ma'am, I've lost the connection.
I think there is some disconnection.
Yeah, ma'am has.
In the meantime, we have got a lot of participants. If there is any question so far, although Madam had been kind enough to explain in such a simple way that even as an oncosurgeon, I was able to make out much of it. So, if there is anything to be added by Rangarao sir is also here. If you would like to add something, sir.
Yeah. Yeah. Hello. Good evening, everyone. I think number one is that, routinely, most of the places we are testing for all the possible driver mutations. While we are getting a very good clue to the treatment, we are also getting confused in small number of patients when we have the expression of two mutations or more, two mutations, because the ALK and EGFR is something which we are seeing, I wouldn't say very commonly, but that really confuses. So one starts thinking, what has gone wrong? Is it that the tumor has got two driver mutations, or is there one mutation which is false positive? So just wanted the speaker to throw light on this. So especially when the EGFR is done by the IHC and the ALK is also done by the IHC and positive. So should we rely on the ALK by IHC, or should we go by FISH only?
Is it okay now?
Sir. So, ma'am has joined, sir.
Yeah.
So, I think she will be able to answer the question in a better way, sir.
Yeah, fine. She got you off. Did you get, Dr. Anuradha, did you get the question or no?
No, I couldn't get the question.
I'll repeat the question in a very brief manner. The question is about finding the double driver mutations, EGFR and ALK. EGFR positive by IHC, ALK also positive by IHC. So what do we take it as? Should we retest the ALK by FISH? And in case that is also is negative, what one to be taken as positive?
Okay.
Because it's a big therapeutic dilemma how to treat.
Okay. So if you get ALK positive on the IC, and as per the WHO guidelines, I think we can consider the ALK positive on the IC. But if it is negative and we feel strongly positive as a smoker patient or something, and clinically if he looks like an ALK, I think we should repeat on the by fish, because sometimes you don't get to see this protein expression on the IC. But if NGS is available, then I think we should take them on the NGS platform.
Okay, but I was talking about the double
My
mutation.
slides all the time missing. My presentation was incomplete also.
Yeah, ma'am. Actually, your presentation had got disconnected, so that's why we continued with the talk. I'll request organizers to please connect the presentation of Madam.
Should I connect? Okay. Should I continue with the talk?
Yeah, ma'am. Please, please.
Okay.
Ma'am, you have to share your slide deck, ma'am.
Yeah.
Organizers, is there any problem with the presentation?
No, I think so, ma'am. Anuradha, ma'am?
Yeah, can you see the slides now?
No,
Not
ma'am.
yet,
We are
ma'am.
unable to.
I'm so sorry.
Your share slides is not coming up, ma'am.
So, ma'am, can we share it from
Here
our
it
end,
is.
ma'am?
Yes, but there were a lot of changes which I had done it actually.
Anuradha ma'am? Hello.
No issues, ma'am. Even if you speak on your side, ma'am, I think you are explaining it so well that it is absolutely crystal clear method of explaining, ma'am.
Ma'am, I think so, ma'am. You have poor internet connection. So can we continue with the question and answer session itself, since you're audible with us? So we'll go ahead with the question and answer session itself.
Jainam, I think Madam is taking time because of that. I think some connectivity issue.
Yeah, right.
So if Dr. Kumar Prabhash is also there and other people are also there, we'll take up the question now.
Sure, sir.
Go ahead, Tejinder.
Okay, so I think we will take Dr. Rangraj sir's question about very first question. I think chat box is totally empty. So I thought I'll just take up a question for others. One question which he asked was, nowadays we do tend to see 2 mutation, or I had seen one patient 3 mutation also. Like I had one patient who had exon 19 mutation positive and also ALK was positive on IHC. So what to do in that scenario? A person has got 2 mutation and patient is symptomatic. Which one to go ahead? Whether to give combine, whether to go for one, or whether to treat for both the ALK and the EGFR? This is a commonly asked question that which sir had asked this question.
Tejinder, we just were analyzing our data regarding this more than one mutation and especially this combination, which we have seen. We had around 20 odd patients, in fact, being precise, 23 or 24 of them. And we did check it, that all the reports which we got it from our routine methods which were used in the lab, yes. Some of them we had verified doing orthogonal technology to suggesting that we are getting the right reports, and again they were positive. When we analyze the data regarding the treatment and outcome, number is small, but it does give you some hints. It does appear that they do respond to EGFR TKI and ALK TKI both, because we had this patient for quite some time. So at the time when we had those, we have treated most of them with first generation TKI in both situations. There are some exceptions, but majority of them. So when we have treated sequentially, either giving EGFR TKI first, followed by ALK TKI, or ALK TKI first, followed by EGFR TKI, looks like they respond, suggesting that looks like both of them has the potential to be driver when we have these both mutations. last, some patients we have, treated them with combination that both TKI. What we can say, it is safe. To say that it is more effective than
Yeah,
sequential, we
can,
can't say for sure. But the combination is safe. We hope it is more beneficial, but we can't say for sure.
Yeah,
uh,
Dr. Anuradha, I think the same question will, because I think because of the time we have come to the question and answer.
okay, fine.
Dr. Rangaraja had basically he had asked the same question about the double mutation.
Okay,
After this double mutation come in place, naturally we come back to you and start asking question.
okay.
Which one you feel is more important? Like Dr. Kumar has summarized very nicely about the data also. And this double mutation nowadays we are commonly seeing nowadays. It's not so uncommon nowadays. So do you agree with this double mutation thing which are there?
Yeah, I can hear now. Yeah.
So can you tell us something about double mutation or three mutation in a single patient?
Okay.
Like
If you're
EGFR.
performing, yeah, if you're performing on the next generation sequencing, then and if you have the double mutations or other than double mutation, we need to look which are the driver actionable mutations which are present. If it is EGFR, obviously we need to go for the EGFR testing. And if it is ALK, nowadays I think if we need to see the reads, how many number of reads are present.
Right. Yeah, madam, you can go ahead. I think lots of connectivity issue from the madam side.
For the EGFR, I think we need to give the preference for the EGFR testing. But again, ALK also is the preference which can be given. But yes, first EGFR and then the ALK.
Kumar sir, Dr. Rangarao has also asked this question: is chemotherapy and TKI better option or just sequential like what you were telling, or dual TKI? Or I think you are preferring more dual TKI, sequential TKIs, right, sir?
So it is just that what we have used till now, but I agree with this proposition that chemotherapy with TKI, if you don't want to use a double TKI, that sounds more promising. Because we do have a hint. Give us some more time. We are going through data more carefully. It does give some hint that control of disease, when we have used EGFR TKI first, has been a bit shorter than what we have seen otherwise in the clinic. So there is something more to it, looks like, but again, no, 24 patients, you have three combinations there. So, tough to interpret clearly, but yes, more and more we believe to throw in, all treatment if they are safe as early as possible, because you don't get a good second chance and third chance in these patients. So if I'm not using double TKI, sure, I know in today's time I'll prefer more of chemotherapy plus TKI, especially first generation. If we are, I'm using it.
Yeah, thank you, sir. Sir, I think we have two more people. Dr. Prabhat Malik is there. Dr. Prabhat Malik. Dr. Preetam Kataria is there.
Yes, sir.
Acha, Preetam, one small question from one for you is that we have nowadays NGS coming up in a big way. So, do you prefer a limited NGS or you go for extensive panel? Limited means like you have this classical AL cross and EGFR and MET and your BRAF, like that. What there's a panel which is going on commonly, which we do. So, do you feel that limited is sufficient, or we should do, if cost is not a constraint, we should go for extensive full like what foundation does?
Yeah, so I think that we should go for a complete NGS where if the cost is not a concern, because it gives us a complete picture of the different mutations which are interplaying, and I think that's how I would sum up that we should do a complete NGS rather than a limited NGS.
Yeah, Kumar sir, anything you can add to it?
So what Pritam said was fine with me. If resources are no constraint, and then good, as much information is better. Only reading report becomes tougher when you have those whole exome data and whole transcriptome data. Limited NGS, we are a bit more tuned to, so reading becomes a bit easier. But then in principle, I agree that more information is not always better, but it does add value
Yeah,
in
it
more
creates
often it
sometimes
can
more
come up.
confusion. It creates more confusion also.
But I feel one more information.
Right, sir. Right, sir.
So
But I think what
Question, can I get the questions on the chats? Because I'm so sorry
ha.
for this
Go ahead.
inconvenience.
So the question which has come in the chat was regarding the dual mutation, what to do, like you had answered also. Second question we had just taken up over here is that whether if given a choice to a patient and cost is not a concern, whether you can just need to do limited or you can go for extensive panel. A second thing which I just want to ask everyone is that,
Can I add one, Tejinder?
yes, sir.
For whole exome and whole transcriptome and those limited. Another constraint remains machines. So if you want to do whole exome and whole transcriptome, most of the center won't have that machine. That requires a huge amount of output, so that becomes a challenge. Cost is not a constraint. Remember, if the cost of whole
Yeah.
exome remains around 20,000 odd, 25,000, whole transcriptome, good lab will give you around 15,000 odd. So that doesn't remain a constant, but it remains what kind of machine you have for
Right.
NGS, because every NGS has a capacity to give you output. So for whole exome, the output needed is pretty high. That becomes a challenge. So once we know all those things, I agree we can choose one of them. And
So
I agree with you can,
yeah. So I think we'll have only one or two questions because one question about to Dr. Preetham and Dr. Kumar sir regarding the ALK. ISC has come positive, fish has come negative. Will you go for treating the patient based on the ISC or will you repeat the fish also again? Which will you give me more importance? Madam had taken up this question during her talk also. Small amount.
so,
Kumar sir.
yeah, so we did analyze our data on this. We did have a fair number of patients of ISC positive and fish negative. Responses to ISC positive patients were absolutely similar to what we had fish positive, means that patients who were IHC positive and fish negative as compared to patients who were fish positive totally. So they were not different. So for me, if your IHC is validated, if your lab is good in doing IHC, they have validated the test, then if IHC is positive, please treat them. In fact, I'll give one more hint. We have also treated patients with called, sometimes IHC they call positive or negative. That's not always true. Sometimes you do get some iffy patient also, IHC positive. But I'll say if you get those iffy, then also treat them. More often than not, they respond. In fact, we published that paper for IHC positive and fish negative patients.
Yeah, because there was one paper on the Alex also, where the alectinib had not done so well on ISC positive and fish negative. One small, not too much of group of patients.
So that becomes a bit of a challenge that
Right.
you'll always get small, but you will get many publications contrary to it with IHC positive, fish negative doing good, because when we analyze our data, we also looked into literature and looked that good IHC gives you a good solution.
Right. Preetham, you want to add anything to what sir has recommended
So,
on the ISC
yeah.
and
So in
fish
this
for health?
situation, we can do a NGS again. I mean, just to look at all this, confusion that has come up. And as sir mentioned, yeah, for ALK, I mean, there's a good concurrence between the ISC and the fish testing for ALK positive patients. So I think even if ISC positivity is there, still we can consider for crizotinib.
So one last question to everyone. Limited tissue, liquid biopsy not possible for non-squamous, squamous, which is the minimum one mutation you will do.
Of course, EGFR.
EGFR. Kumar sir.
I agree. I agree. So, this is the importance of working.
Okay, I'll add two
same
mutation. I'll add two mutation. Madam has added one EGFR. Madam, which one else you will add apart from EGFR?
ALK, AML for ALK.
Kumar sir.
Yes.
I'm just. This is like a. I don't know from where I took the question, but it's fine.
Yeah.
So, madam, sir will also.
Rajinder, this is a very valid question. We come across this situation. Tissue is limited, and what do we do? And tissue being limited is a fairly common situation in lung cancer.
But here I can come over. Like if we have the limited tissue and if you have at least 10 nanogram of DNA total, I think we can still go on the NGS and have a big spectrum.
Okay.
Various biomarkers.
May I just, Dr. Tejinder, with your permission? So,
Yes, sir. Yes, sir.
Actually,
Yeah.
yeah, no, in a institutional practice, a big practice where medical oncologist gets the direct case is one thing, and when a pulmonologist is investigating is another thing. Even if there is a visible mass or a lymph node in the supraclavicular, their tendency is to go for a bronchoscopy and get the TBNA. Hardly they will palpate the supraclavicular node or anything else, and they won't even look at a CT guided true cut biopsy. They will just go for that, and then they have a limited biopsy. And when you talk to the patient that biopsy, so then there's a huge resistance, and that's a real practical problem that we are finding in, because they think that the TBNA is the best way of getting the tissue directly from the tumor, whereas which is may not be true, and they say, no, this is not a tumor, this is a consolidation, and lots of things which something drives them. Getting the adequate tissue is a big problem.
Yeah, but still,
And
sir,
when
one
we
question
propose
to
that, okay, once again, lymph node biopsy.
Again, I can come over here. Like suppose if tissue is limited, if liquid biopsy is not possible, but other than blood, cfDNA of blood, if we have the and if it's a metastasis case, then and if you have the other than blood sample like CSF, or if you have ascitic fluid or the pleural fluid present, still we can derive the cfDNA and we can go on the NGS platform for that.
Yeah, madam, many times, you go on telling them the investigation, they get bored. That's the biggest problem with the private practice. So one last question to, yes, sir. Preetham, you want to add anything to it? Which one you will do? Limited tissue? Which you want to send? Two investigation, only two investigation.
EGFR and ALK, sir. I think I concur with both of them. Yes.
So sometimes, Kumar sir, will you agree if you're given a choice EGFR and PDL1, EGFR ALK?
The EGFR ALK.
EGFR
I know if it is ALK, positive, I will be unnecessarily using it. And if PDL1, I don't know, then also I have a chance to give a good treatment to the patient in combination.
Okay. No, that's thank you, sir. Thank you to the organizers. I think we are running short of time. Thank you.
Yeah, I'm very sorry for my bad network on my side.
Madam, your presentation was very good. Very good. Thank you, madam.
Thank you. Thanks a lot, ma'am. Your presentation was so lucid that I'm saying so. As an oncosurgeon, I could make it. So
thank you so much.
And thank you, Tejinder sir.
Thank you so much.
Thank you.
Now is the time to move to next session, where there will be a talk by my senior, Dr. P. Suresh, who will be talking on immunotherapy in locally advanced and earlier stages of lung cancer, rationale, evidence, and implications for the multidisciplinary team. Over to Dr. Suresh, who is a consultant medical oncologist at Army Hospital R&R, Delhi. Suresh, sir.
Thank you, Colonel VP Singh. I'll just share my screen.
In the meantime, let me put it officially in recognition that there is a lot of medical oncology that I have learned from sir.
I think you are a complete oncologist who radiation, medical oncology, I think all of these are embedded in you, and you have a natural interest for going out of your specialty and taking extra initiative in the other specialties also, which is very good, I think. Thank you, Colonel VP Singh. And gentlemen, I hope my screen is seen and I am audible.
Yes, sir.
Both. Okay. Thank you so much to the organizers for giving me this opportunity. So I will be speaking. This is what the topic was that was given to me: immunotherapy in locally advanced and earlier stages of lung cancer. So this is immunotherapy in the earlier stages, not the advanced stage, where we are generally used to using it. Okay. So globally, about this is the percentage of resectable and unresectable lung cancers, about 25%, and 75% is considered unresectable. The Indian data says about 3.5% is stage 1 and 2, and stage 3A is about 13%. And most of the others, almost 80%, is unresectable. So the standard of care for a resectable or early stage lung cancer is that we discuss in a multidisciplinary tumor board, and ones that are resectable, they go for surgery, At times, we do give neoadjuvant chemotherapy or radiotherapy. There are certain preferences for that, and the ones that are unresectable go for chemoradiation. And then there is further adjuvant chemotherapy or chemoradiotherapy. So this is usually the sequence in early lung cancer. So the ones who receive neoadjuvant treatment are, there is a sort of consensus, I think, mostly among us. N2 nodal disease at presentation, tumors not amenable for upfront chemoradiation. This is a very rare indication in view of large volume of disease leading to radiation dosimetric constraints, or tumors that were borderline, or otherwise resectable tumors deemed inoperable due to the poor general condition of the patient. So now coming to the topic specifically, which I am going to discuss, is the role of immunotherapy in the neoadjuvant setting first, neoadjuvant and the consolidation and adjuvant. There are three roles for immunotherapy, which I am going to discuss. So what is the rationale of using immunotherapy in this setting? So we all know the how the immunotherapy works, especially the immune checkpoint inhibitors. I shall not go into the details of it. This is known to all of us very well. And what does chemoimmunotherapy do? So we know that immunotherapy unleashes the T cell, the potential against the tumor. And how does chemotherapy add on to this? So chemo-induced cell death of the primary tumor results in tumor-specific neoantigens being released, which results in an increase in the immunogenic response of the primed neoantigen-specific T cells. So it's a better T cell response because of the neoantigens that are released by the chemotherapy. Now, the concept of neoadjuvant versus adjuvant immune checkpoint inhibitors. So what is the advantage of using an immune checkpoint inhibitor in the neoadjuvant setting? So the tumor is in situ here. We have the immune system which is facilitated by more efficiently by profound antigen load. So there's a large antigen load that is there, which we can release and stimulate the immune system. And most importantly, this one is very important. The last one, the induction of the immune response before surgery may result in immune memory and contribute to long-term anti-tumor response. So giving an immune checkpoint inhibitor in the neoadjuvant setting may even result in its advantages in the adjuvant setting. The memory may remain, and there may be advantages even in the adjuvant setting. So this was the rationale behind using these agents in the neoadjuvant setting. So now let us see, is there any evidence and what is the level of evidence for using these agents? So it all started with certain small studies of 20-25 patients, and these were the initial publications which were published in the Annals of Thoracic Surgery. So Shaft and Watt et al. These are the two important studies. So both these studies had about 21 to 25 patients, and they used neoadjuvant nivolumab, and one of the studies also used ipilimumab also. So about 2 cycles, 2 weekly, and from the first cycle within 4 weeks they did surgery. So basically they were all looking at the safety and feasibility of lung resection, not at the other advanced parameters like survival. And they found that it was safe and feasible. However, there was some amount of fibrosis in the mediastinum in the hilar region post immunotherapy. So these were the findings initially. So the first major study which evaluated more than safety and feasibility is this study which was published in the New England Journal of Medicine, the neoadjuvant PD-1 blockade in resectable lung cancer by Ford et al. So 21 patients again. So gentlemen, all these studies are of very small number of patients, obviously. So 21 patients, untreated and resectable stage 1 to 3A, stage 1 to 3A non-small cell lung cancer. 62% were adenocarcinoma, 81% were stage 1, stage 2 or stage 3A. So they gave nivolumab 3 mg per kg into 2 doses and 2 weekly. And the surgery was 4 weeks after the first dose. So 20 patients out of these 21 underwent surgery. The primary endpoint was again safety and feasibility. However, there were secondary endpoints. These are the newer developments. That is one is called as a major pathological response, and what are the genetic correlates to a pathological response. So this terminology called as a major pathological response was introduced in this study, which meant less than 10% viable tumor cells in the pathological specimen. So this was seen in 45% of the patients, looks high in terms of percentage, but actually 9 out of 21 patients. And a CR, pathological CR was seen in about 3 patients, that is 15% of the patients. So the PDL1 was not a good marker, and as I had mentioned, the secondary endpoints were also the genetic correlates. So the whole exome sequencing showed that higher the TMB, more was the major pathological response. So TMB was a better marker for pathological response. Another important finding was that the tumor-specific T cell clones were seen in the tumor as well as the peripheral blood. Both these increased after nivolumab was given in patients with the major pathological response. So some of these clones were not seen prior to nivolumab. So some new clones had appeared. So this is what we meant, that it may stimulate the immunity and also produce a memory T cell which can act for a longer period. Another important finding from this study, which gave us new knowledge, was that there is a discrepancy between a radiological assessment and pathological assessment post neoadjuvant immune checkpoint inhibitors. The post-treatment CT scans showed mainly stable disease. There was partial response in about 2 out of 20 patients and progressive disease in 1 patient. In the 2 patients with pathological complete response, there was just stable disease on CT scan. So this tells us that the radiographic assessment by CT scan may not actually be a good method. It is not accurate after neoadjuvant immune checkpoint inhibitors. This is mainly due to the T cell infiltration and peritumoral inflammation. So a new terminology called as the immune response path response criteria, immune-related path response criteria was made after this study. So the main features of this immune response was that there is something called as a regression bed in the pathological specimen. The regression bed, the area of immune-mediated tumor clearance, this was the area that accounted for the CT scan discrepancy, because in this bed there was immune activation with dense tumor-infiltrating lymphocytes and macrophages and tertiary lymphoid structures. There was massive tumor cell death with cholesterol clefts, and there was tissue repair, neovascularization, and proliferative fibrosis seen. All these were seen more in the patients with major pathological response. So this was the difference when we used immune checkpoint inhibitors in the pathological specimen. So further studies which were done later used other agents like atezolizumab, again in the stage 1B to 3B neoadjuvant setting, 2 cycles of atezo followed by resection. Driver mutation patients were excluded. The major pathological response was 18% and PCR was 5%. PDL1 was predictive of benefit in this study. So as usual, the confusion of PDL1 and TMB continues in the neoadjuvant setting also. Then we move on to combination immune checkpoint inhibitors. So this is a NEO-STAR trial, nivolumab plus ipilimumab versus nivolumab alone. Again, small number of patients, 21 versus 23 patients. However, as we can see here, there is a major improvement in the pathological responses. Major pathological response was 33% versus 17%, combination favoring the combination. And out of this 33%, 29% were pathological complete responses. So the PDL1 levels directly proportional to major pathological response as well as complete response. The combination was better. There was no perioperative morbidity or unacceptable toxicity. This was the NEO-STAR trial, and this showed that the combination immune checkpoint inhibitors may be better than a single immune checkpoint inhibitor. So now we move on to the neoadjuvant chemoimmunotherapy. So we all know that these two, the combination immune checkpoint as well as the chemoimmunotherapy are well established in the advanced stages. So what is the evidence in the neoadjuvant setting? Again, a multi-center phase 2 trial, 46 patients totally, both adeno as well as squamous cell. This was a stage 3A, mainly stage 3A. So 3 cycles of Nevo 360 mg. So the 3 weekly dose with Pacli and Carbo. Surgery was done after 6 weeks of chemo, and adjuvant nivolumab was continued for 1 year. So this is a combination of neoadjuvant plus adjuvant therapy. 41 of the 46 patients underwent surgery. The major pathological response was seen in 83% of the patients, that is 34, and about 71%, out of these about 71% were actually complete responses. So 24 of them had complete responses. The 24-month PFS was 77% and the OS was 90%. This was recently published in the Lancet Oncology. So that atezo plus chemo, that was Nevo plus chemo. So this is atezo plus chemo, 30 patients, adeno and squamous both, never smokers were excluded. Pre-op evaluation of mediastinum was not required. Pathological evaluation was not required. Atezo plus nab-pacli weekly and carbo 3 weekly. 2 cycles. There was 4 cycles were given totally. There was a reevaluation after 2 cycles. If the CT scan showed progressive disease, the patient went for surgery directly. If it was PR or SD, that is a partial response or stable disease, 2 more cycles followed by surgery. There was no adjuvant therapy in this trial. 4 out of the 30 patients did not undergo R0 resection. There were no major side effects. So now if we see here, this is the first trial which gave us a breakup of adeno versus squamous cell carcinoma. So we see that out of the 17 adenocarcinoma patients, a major pathological response was seen in 18 of the patient, in 8 of the patients, that is 53%. And out of this, 33% had complete pathological response. The same was much higher in the squamous cell carcinomas, 80% and 50%. So PDL1 here did not predict benefit. And the reason for the squamous cell carcinoma patients having a higher pathological response was hypothesized to be likely due to increased baseline tumor necrosis in the squamous cell carcinoma patients. So where do we stand after all these trials? Single agent immune checkpoint inhibitors, combination immune checkpoint, and chemoimmunotherapy, all phase 2 trials and with very low number of patients. So where do we stand now? So the biomarkers, do we have good biomarkers to choose these patients in neoadjuvant setting? PDL1, there are some positive and some negative studies. Tumor mutational burden, the NEVO EP studies showed MPR was directly proportional to TMB. But one thing was clear, that the driver mutation patients should be generally excluded from these studies. The problems, immune-related side effects, though not very severe, but it is a factor which we have to remember. Adhesions and fibrosis during surgery, this was definitely increased. And the resistances due to the tumor microenvironment. And one more important point was that the reassessment post-immune therapy with CT scan is inadequate. PET scan may be a better modality. However, even in PET scan, the tumor infiltrating lymphocytes can increase the FDG uptake. Hence, it is very important to time the PET scan properly. So this is the summary of the trials I just mentioned. I shall go to the next one. So these are the further ongoing phase 3 neoadjuvant immunotherapy trials in early stage and locally advanced non-small cell lung cancer, which we will be eagerly awaiting. The Checkmate 816 study, 642 patients. So a very good study. EFS and PCR are the primary endpoints. NEVO EP followed by surgery and followed by further chemotherapy versus chemotherapy only, or NEVO plus chemo. Then we have, so the NEVO-based studies, and the IM Power 030, that is atezolizumab-based study, and the Keynote 671, the pembrolizumab-based study. So most of these studies are neoadjuvant followed by adjuvant immunotherapy also. So ongoing studies of the adjuvant immunotherapy, if you see here, in the early stage as well as locally advanced. So there is a study of the Anvil or the Alchemist study when nivolumab is given as for 1 year. The IM Power 010, again atezolizumab in the adjuvant setting. And of course the Keynote 671 where the pembrolizumab is being given as neoadjuvant plus adjuvant setting. So there are only adjuvant immune checkpoint inhibitors as well as neoadjuvant and adjuvant immune checkpoint inhibitors. The number of patients are quite huge. The primary endpoints are good, DFS and OS. So we shall be eagerly awaiting the results of these trials. So the implications for our practice or for the patient as of now, it is quite in the nascent stages, early stages, I would say. The trial results are quite promising. Advanced lung cancer, the immune checkpoint inhibitors have established their role. However, in the early and locally advanced stages, it still is a controversial setting. Initial studies, which I have just mentioned, have found them to be very effective and safe. The problem areas is how do we identify who are the suitable patients, how long to give, how much to give, which is the best regimen, which is the best biomarker, and how do we select the right patient, and is the major pathological response a good alternative endpoint. So this is about immunotherapy in the neoadjuvant setting. A small talk on the immunotherapy in the stage 3 setting, which is because that is also a locally advanced setting. So we know that the stage 3 unresectable NSCLC, the concurrent chemoradiation, is the treatment of choice after a multidisciplinary tumor board discussion. And we know that post chemotherapy, we have tried various methods of consolidation, increasing the radiation, giving more chemotherapy, or adding targeted therapies like cetuximab. Most of them have failed and not helped us in improving the survival. So till date, there has been no therapy that has that has been used in the consolidation and given us a better survival. So durvalumab is the first agent which is come up and has been approved in this setting. So these are the results of durvalumab, which all of you are familiar with. So just to remember it once again. So the PFS was highly significant, 17.2 months versus 5.6 months when we give durvalumab as consolidation post chemoradiotherapy. And the overall survival was also quite significant. Median survival, I think, about 45 months in the updated analysis versus 29 months in the placebo arm. So I think these are results that are very, very good and has changed the standard of care in the unresectable locally advanced lung cancer setting. So the real life data also has come after this specific trial, and those data also show that durvalumab has been very effective or as effective as in the trial setting. So the responses and even patients who started 42 days or even later after the chemo radiation, even those patients had a very good response to durvalumab. So what are the ongoing trials? There is durvalumab being tried as the in lieu of chemotherapy along with RT or along with chemotherapy and RT, and followed by durvalumab in the adjuvant setting. And then we have all the agents, that is nivolumab with radiation, atezolizumab with concurrent chemoradiation. So all of these agents are being tried, pembrolizumab with concurrent chemoradiation. All of these agents are being tried in a very good number of phase 2 and phase 3 trials in the consolidation setting. So with this, ladies and gentlemen, I thank you for a patient hearing, and I have finished my talk. If there are any comments or doubts, I would be ready to answer them.
Thank you, sir. In fact, Ranga Rao sir has already put his remarks. It is excellent review. So now I hand over the baton to Dr. Ullas Batra for a panel discussion on optimal management of stage 3 NSCLC, a case-based discussion. Dr. Ullas Batra.
Okay, thank you. And
Sorry to interrupt you, sir. Before we start, I request all the panelists to keep on the camera on. And the eminent panelists are Dr. Captain Tilak, Dr. N. Vamshi Krishna, Dr. Abhishek Mahajan, Dr. Tejas Pandya, Dr. Ramakant Deshpande, Dr. Sabita Jimnani, and Dr. P. Suresh. So over to you, Dr. Ullas Batra, sir.
okay, thank you. Good evening, everyone. And can I also know the reason of asking everybody to keep the camera on? I mean, is it to make sure that nobody sleeps?
No, sir. It's live on the website. Sir. It's going on live
It's
on
live on the website. Okay.
Yes, sir.
Okay. So good evening, and can I have my slides over here? Because for a change, they didn't allow me to present my own slides. So all the cases which have been given over here are.
Can you just display sir's presentation?
Yeah. Okay, so a disclaimer, these slides are not mine. Okay, these were mine around 2 years back when AstraZeneca gave it to me at that time, and now again we are using them. And so we will be discussing an optimal management of stage 3 non-small cell lung cancer, a case-based discussion. It was, I think it was done around 2 years back in a very magnetic field meeting where a lot of audience were there and a good interaction was there. Let's see how does it work in the virtual way. So Suresh has gone back to sleep. So Suresh, you are off to sleep. Suresh has turned off his camera. This is for everyone to know that I'm looking at everyone. Okay. Okay. Can I go to the next one? So my first reactions when I saw the panel discussion of a potentially operable stage 3A non-small cell lung cancer, there were 3 medical oncologists. There were 2 surgeons, or 2 heavyweight surgeons, I must say, 1 radiation oncologist. So next one, please. I mean, that was my first reaction. It's not right, actually. It's actually bahut nainsafi hai too. Dr. Sabita is having a good laugh on this. So I thought whether it is bahut nainsafi hai, or the next one, please. Or is it a signs of things to come, that like medical oncologists have taken over all the stage 4 lung cancers and everything. I mean, are we going to take away the stage 1, 2, 3 also? So I'll start with the senior most amongst us, Dr. Deshpande. Sir, good evening.
Good evening.
What do you think, sir? बहुत नाइंसाफी है या medical oncologists are going to rule the roost?
No, you were saying that the camera actually is on only because just to ensure that we are not asleep. Actually, what you're saying is a static film. I'm not here.
Okay. Sir, are you not here or are you not then in stage 3 also? The first week
I don't think there is a nainsafi. This is all relative weightage which is given. You know how you calculate your p values and your forest charts and all that. So it is just like that. So it's two surgeons equal to, one radiation oncologist is equal to two surgeons is equal to 3 medical oncologists. That
I knew that will come, sir. Dr. Sabita, what is your take on that? I'll then go to Dr. Tejas and then I'll go to medical oncologist.
I agree, बहुत नाइंसाफी है, but there should be lesser of medical oncologists and little more of radiation oncologists.
Okay, we will find out, madam. The survival which Suresh showed was there only because of durvalumab. The survival has never been because of intensification of radiation or surgeons or whatever. Okay. Dr. Tejas, your take? Are you equivalent to the surgeons?
As I'm sitting in the corner, sir, I'm feeling like I've been cornered. But I think I'll try to justify my specialty, sir, and the treatment in the management of stage 3.
Fantastic.
Okay, before anything, Ullas, let me take it back to your field. Okay, if you take the capacity of cure as 100 in cancer lung, maybe in stage 2 or stage 3. Okay, let's take over stage 3. What is the cure potential of each discipline when it's taken in individually? You tell me that.
Sir, 3 months back, I would have deferred, but just the data that Suresh showed, I think, sir, you will have to defer. I will show you some data, sir.
No, you talk of percentage-wise.
I am the moderator right now, so I am not going to interrupt in that. I will take it to Tilak now. Dr. Tilak, what do you say? Dr. Ramakant Deshpande is saying surgery is the only thing which can cure.
No, I'm not saying only thing. The contribution is the highest. That's all that I'll say.
But we will. I mean, Dr. Tilak, do you differ?
So my take is that there are 3 medical oncologists and 2 surgeons and 1 radiologist. Basically,
and one from the army. That's why one only was good enough because we never speak anything in front of Indian army. That so that you have an unfair advantage.
So more and more of medical oncologists are now coming towards assisting the others so that the better outcomes for the patients. I would take it that way.
Politically correct answer, Tilak. Okay. Vamshi, your take, and then we'll move on.
We have to work together and we will work together. We respect the surgeons and we hope they respect us. Let me leave it at that.
That is the difference with Dr. Ramakant Deshpande and Dr. Sabita bring over there. Another meeting, we would have eaten the surgeons alive, but nobody dares open their mouth against this. Okay. Let's go on. Let's go on to the case. Next slide. So we have a 67-year-old male with no comorbids, ECOG PS1. He was evaluated for cough and upper backache and weight loss. Next slide. A PET CT scan was done, which basically showed a soft tissue mass involving the right upper lobe, measuring 6.5 by 6.7 by 5.3 centimeter. Another centimeter-sized consolidatory cavitatory nodule was there. It was not infiltrating mediastinum, no bony erosion. Contralateral lung was normal. And there were multiple lymph nodes in the right paratracheal, right peribronchial, which were largest was measuring 2 centimeter, SUV of 5.53. So here is where, for the next 4-5 slides, we have images of the scan. I'll ask Dr. Abhishek Mahajan, the camera is still on. So can you please have a look at the scans and let us know your findings? So can we just go to the next few slides? Yeah, this is just show in the slides first, and then he can comment maybe on that. Next one. Okay, next one.
Can you move on to the next one?
Yeah, sure. Abhishek, you can take over from here.
Yeah. So if you see in the first slide, which was the routine CT
Can we go
slide.
back to the earlier one?
The first slide, yeah. This is a contrast and CT slide, which is showing the lesion in the right upper lobe, and it's like infiltrating the probably the pleura I'm not seeing, and it's closely abutting the esophagus and the trachea and the mediastinal structures. I thought that the report said that it's non-infiltrative.
The more closely it is abutting the esophagus and this thing, the lesser the smile is appearing on Dr. Sabita's and Dr. Ramakant Deshpande's face. So don't see
I
so
mean, like,
closely, okay?
yeah, it's like distorting also the lumen. It's like pushed. Esophagus is pushed actually to the contralateral side.
Okay.
If you go to the next slide, please. Yeah, so now this slide and the previous slide does not match, but the PET avidity is seen, and there's a hilar node also, which we can see in this particular slide. And go to the next slide. We can see a discrete nodule which is separate from the main lesion, and the CT image is not there, but probably appears to be in the middle lobe.
Okay.
Yeah.
Next one.
I think that's it. The 3 slides.
I can next one, please.
Next slide, please. Yeah, so now there's a carinal node, which is probably showing some uptake, and the SUV, I think you showed that it's 5.3, the SUV of the node.
I think yes, it was somewhere around that.
Yeah.
2 centimeter lymph
So
node.
now here we can see that this particular lesion is closely abutting. Yeah, and the lesion, it's very difficult to say that the pleura is not invaded, and the mediastinal structures, I think an EBUS and a EUS would, the upper GI scopy would help.
Okay, next one.
Yeah, the node is definitely showing uptake, and it's a.
Okay, I'll go to Dr. Sabita at this particular point. Madam, the node is definitely showing up, lighting up. What is your take on the scans? The first cursory look on that.
So it's a locally advanced malignancy, definitely T3, T2B maybe 5 to 7 centimeters. And there is uptake in the hilar and the
There was another nodule in the same lobe, I guess.
Yes. So say according to Abhishek, it's middle lobe, but probably I think it's close to the fissure and maybe the lower lobe only. And we will not know unless we see the lung windows. But there is a node in the mediastinum which is seen in the precarinal preapial area, and it has an uptake which is slightly less than the primary. And as a part of the staging, we would also like to include MRI brain, and this patient will definitely need invasive mediastinal staging. EBUS first, and then we'll decide on mediastinoscopy.
Okay, we will go on. Next slide, please. Next slide. I think we'll just get away with this. Next slide. Next. Just go forward. Okay. A biopsy was done initially over here, which came as non-small cell lung carcinoma favors adenocarcinoma. We have not yet done a EBUS or a EUS right now. So the medical oncologist in the house, Suresh, want to do a EGFR, AL, cross, PDL1 right now?
I think it is stage 3 as of now.
Yes, at present.
At present, it is stage 3. So it will. I wouldn't mind doing it, but it won't change my treatment as of now.
Okay. Okay. Go ahead. Next one. Next one. Okay. So I think Dr. Sabita did briefly mention about the staging investigation, but let's go to the medical oncologist first. You know, I mean, the surgeons will do all the staging one. So Tilak, this guy comes to you. Before referring the patient to the surgical oncologist, what would all investigations do you think or do you regularly do in your institute?
So for the staging right now, we have a PET CT and we have the confirmatory biopsy. So like rightly mentioned by Dr. Sabita, if you're looking for a curative intent of treatment, probably an MRI brain. And definitely with the precarinal lymph node lighting up on the PET CT, the pathological staging of the lymph node by a mediastinoscopy. EBUS, sometimes we have an access to it, sometimes we don't. So it is plus minus in our
I basically wanted to ask you about the EBUS. So what is, you know, I mean, for the surgeons and for us, it is easy to say we do EBUS for everyone. What is the state of EBUS in across India? That is what I wanted to, you know, ask. And then I'll go to the other medical oncologist,
right?
Then from the radiation, and then Dr. Ramakant Deshpande.
Right. So
the options.
The EBUS, right now we have facilities available in most of our cancer centers, barring a couple of them who do not have the access to EBUS. So where it is available, we do resort to it. We do access EBUS. In the places we don't have, the patients have to pay to outside to get it done, and that requires admission outside, etc. So there,
what is the comfort level of the pulmonologist and the surgeons and the medical oncologist, and what is the concordance rate between the initial findings and the final biopsy report?
So most of the centers where we have this facility, the pulmonologists are trained in EBUS, and they do resort to it when we ask for it. They're quite comfortable to do it.
Okay. Suresh, can you show me the choices also, Suresh?
Yeah, so I think EBUS as well as mediastinoscopy, there's a slight difference in the access which it provides. So EBUS generally, if I am right, the pulmonologist will agree subcarinal node and some area near that it's easier for them. Whereas mediastinoscopy gives access better in the higher region.
Suresh will talk about the EBUS and the mediastinoscopy by the surgeons. You tell me how often do you get a EBUS or a EUS done for a mediastinal staging, or your surgeons believe that they should go ahead and do a mediastinoscopy? That's what I'm asking you in your center.
Okay, so surgically resectable lung cancers, we rarely get them. But as you mentioned, we have got a very good pulmonology center here, so we are doing it regularly.
Okay, Vamshi.
So in this stage, I think the role of a EBUS is to confirm that it's an N2 disease, and one that is easier done with a EBUS. I don't think there's any point in doing a mediastinoscopy if you have an EBUS positive. Most pulmonologists are able to do it. My center is doing quite a lot now. So I think if we have, and the decision, if what you're asking, who will decide? I think that will be done in an MDT. I think that is very clear. We will not decide on my own and then send, do you do this, you do this. We'll discuss together. And most centers would opt for a EBUS first. I don't think mediastinoscopy is that commonly done for this kind of a disease where you just want to prove that it is a malignancy.
Okay, Dr. Tejas, and can I have the options also here, Dr. Tejas?
Yeah, so I absolutely agree with Dr. Vamsi. I would definitely discuss this case with my surgeon. And as we all know that the sensitivity of a PAT is almost 85 to 90%, and a specificity is ranging up to 90 to 92%. Whereas in EBUS, we would be getting the sensitivity specificity at the range of 92 to 95. So I don't think so we would be getting any, much larger picture by getting an EBUS oblique mediastinoscopy. Definitely no mediastinoscopy. But even I would say EBUS also, as my surgeons won't be that, pro for surgery in this kind of a patient, in which case there is an ambiguity where it is involving the esophagus or not. So if I'm planning to treat with a definitive CCRT, I would not even think for a EBUS as well.
So my point here, I'll come to the surgeons later, but Dr. Tejas, my point is, and this is always that I ask every time, for the surgeons, they want to see whether there's a tuberculosis in the mediastinum and all. Why doesn't it make a difference for the radiation oncologist? Let's say you do an EBUS and all the lymph nodes come as negative and they come as granulomatous. Will not your radiation field change?
Exactly. So yeah, now coming to this point, sir, very good question rather. There was a role of elective nodal irradiation that was basically a contralateral lymph nodal involvement in the radiation fields, which was earlier in the 90s. There were few trials, RTOG and EORTC. They said that even IFI or elective field irradiation that is giving almost similar overall survival advantage rather than doing an elective nodal irradiation that is of a contralateral side. Now coming to the part of ruling out tuberculosis, as the PAT scan has got almost similar sensitivity and specificity compared to EBUS, and my radiation portal definitely is not going to change, and that too by doing an FNSE. I don't know what sort of amount of tissue I would be getting that would be giving me a actually true result of whether proving or not proving the disease. I would rather start with the definitive intent treatment, doing a PAT and an MR brain.
Ullas, can I just make a comment? I mean, what you're saying is very important for a stage 1 and 2. I would, be very, very aggressive about it. This form of a stage 3 with these lymph nodes, such a large tumor. I mean, how commonly are we seeing granulomatous? I don't know.
Okay,
I mean,
let me
exactly.
Let me ask Dr. Ramakant Deshpande.
It's not very rare. I would say that
I would
it's not
agree
very
with
rare.
that.
Even large tumors, you will find that you will find nodes. In fact, recently I had one patient just like that. Now see these anecdotal cases.
Sir, just 1 second, sir. Dr. Ramakant. Sir, can I have the choices also? The guy who is controlling, can you show me the choices also? So please go on, sir.
Yeah, see, ultimately what happens is you were asking about the relative merits of mediastinoscopy versus the EBUS and all that.
Yes,
see, the
sir.
whole thing is, if you really take an all India kind of a look, the whole policy of whether you need to do an invasive staging, first and foremost, is depends upon, are you going to be going to have an invasive thoracic surgeon sitting there, right? Now, what images what you showed here will show that you need a man or a woman probably, sorry Savita, no offense there, Somebody
Savita won't even ask her, she'll operate first.
Savita will, the reference will come only for probably just for, file a discharge card or something like that.
And the trauma center for the medical oncologist who doesn't refer to her. The reference will come only for that. Reference will never come for the patient.
Yeah. So unless and until you have an aggressive surgeon who can actually, take, if required, even a vascular sleeve or something.
Have you ever seen a surgeon who is not aggressive, sir?
Oh, I have seen a few.
Okay, I am yet to see, sir.
Less aggressive, I would say that they claim to be wiser, but my simple this thing is less aggressive. So that is how it is. That is one. So if you don't have a surgeon, then don't talk in terms of whether this is good or that is good, because both will equally mean the same thing. Number two is mediastinal staging going to make a difference for you is the second thing, which means that are you contemplating a pre-operative kind of a chemotherapy for that patient, or will you still go ahead with surgery? If you're going to go ahead with a surgery with an intention when you have a single station involvement in a mediastinum, which is resectable, then why do that mediastinal this thing at all? This is the number two. Number three is, I don't think that PET scan and EBUS are equipotent, not at all. I would not agree with that statement at all. These are totally different areas. And I would see, ultimately, one gives you a tissue diagnosis, the other gives you just a uptake. And in almost about anything between 10 to about 15% of patients, you can have both tuberculosis and malignancy together. True. Or you can have only a tuberculosis, which gives an exactly the same kind of a picture as a malignancy. Lastly, ultimately, what you need to do is you need to get a staging. I mean, if you just treat this patient with chemoradiation therapy, presuming that it is a stage 3B or something of that sort, I think you're being unfair to the radiation and the medical oncologist, because you're not giving them a correct staging. So these are the things what I personally feel. So this patient actually needs to go for a tissue staging. The easiest way, because of this location and the size of the uptake and all that, would be an EBUS, and that should give a result in about anything from 95 to 98%. With a needle size of even 21, your chance of getting the tissue diagnosis is over 95%, I would say.
Okay, I would agree with sir that we definitely need a EBUS and EUS. Okay, what about combined EBUS and EUS? I mean, the data that we always quote is for combined EBUS and EUS.
See, ultimately, yeah.
Can I include Dr. Sabita for that, sir?
Savita, I think will have current experience in this particular thing. Unless the nodes which are involved are in station 8 and 9 or very high, this thing, number 2 or something, US also helps. There's no two ways about it, but it is all in specific areas. I think Sabita can tell you better.
Okay, and Dr. Sabita, one was about EBUS and EUS, and you said definitely this patient will need mediastinoscopy. So your thoughts on this?
So first, let me talk about the PET CT. There is a Cochrane meta-analysis with 8,800 patients, which says that PET CT is not adequate for mediastinal staging. So even if you have uptake, 20% of the patients can get upstaged. So these nodes may actually be negative. And they have seen in stage 1 patients, which were 3,000 in this study, 3,000 of the patients were in stage 1. And especially from tuberculous endemic countries, they will have false positive mediastinal nodes. So if you have even a T1 lesion, which is central, you will need to do invasive mediastinal staging. Now, invasive mediastinal staging has two parts. One, the initial you should start with, which is according to most of the guidelines now, is endoscopic staging. And if that is negative, then you go ahead and do mediastinoscopy. The reason for this is endoscopic techniques are operator dependent. Most of the literature that we have is from high volume centers, and most of the important studies, including the randomized control trial by ANIMA, was conducted by EBUS, which was being performed by surgeons. The biggest name in EBUS and endoscopic staging now is Yasufuku, who is also a thoracic surgeon. So even in our center, the EBUS program is led by surgeons in combination with intervention radiologists and pulmonologists. So EBUS accesses the same stages as mediastinoscopy: bilateral level 2, bilateral level 4, and subcarinal. When you do combined EUS, it will add stations 8 and 9. So unless on the imaging, if you see something lower down below the subcarinal and you want to prove that it is metastatic, then you will combine it with EUS. Some stations you may do a bronchoscopic insertion into the esophagus, and you can access the nodes from there too. So the only randomized control trial that we have, which was published in JAMA in 2011 by Anima, had used EBUS and EUS together. And if your EBUS and EUS is negative, then you need to do media stenoscopy.
Sabita, one query. How often do you see station 8 and 9 positive without higher stations being positive?
Very rarely, sir, less than 5%.
True that. Okay, I think we have got two questions. One is from Kumar, which says if there's a right-sided tumor, lower lobe with 2L positive or higher opposite positive, can we irradiate? Dr. Tejas.
Can I, just add to that question, maybe which doesn't come out in the chat, is that that node was not there. It came positive on, EBUS.
On EBUS.
Does that make a difference in your management? And that may give an answer that should we require or not. Lower lobe, upper lymph node, opposite side lymph node, on EBUS, which was not there on the scan.
On the PET-CT or CT scan.
So that's what the question you wanted to ask, isn't it?
Yes, sir.
Right-sided lower lobe tumor with
upper paratracheal N3 or higher.
Sir, it would actually entail a very large volume of lung. So if I would be doing an IMRT planning, I would definitely look for V20, receiving 20 gray.
So, Dr. Tejas, isn't that the question that I was asking, that if it is required for the surgeons, similarly that is required, EBUS staging is required for the radiation oncologists also, right?
That is to prove the contralateral lymph node, sir. If, as we are talking about our patient, if it's the ipsilateral lymph node, as such, it is going to come into my field. So for that particular patient, I would not look for an EBUS.
Okay. I think we go ahead.
I give a
because that is going to come into my field anyway.
And Ullas, I give a situation to Tejas. So he went to someone, chest physician, he does EBUS, and the 2L is positive, or level 10 is positive. What do you do now?
So right lower lobe, L10 level 10 is positive.
We don't do it. Don't get me wrong. I'm no, situation. We also don't do it.
Sir, I think it would definitely entail a very good large volume of lung. So I don't think so. V20 we would be able to respect. 35 to 40 gray we generally say. Volume receiving 20 gray should be less than 35 to 40%.
So Kumar, can I have your take on this? Should we, if we are considering somebody for definitive CT-RT, should we be doing an EBUS or not? I mean, what do you say? What do you do right now over there?
So we don't do it. We discuss a lot. Dr. JP has views on Monday different and Wednesday bit different. But having said that,
so what are the views on Monday and what are the views on Wednesday and what changes in between?
So can I button?
So what we sure now that if we pick up those lymph node on EBUS, have people treated differently with radiotherapy and the outcome. That has not been done, and that's the reason we don't do it today.
So Dr. Sabita, your take.
Yeah,
on Thursday.
To me, if it is going to change their field of radiation significantly, then they should ask for an EBUS.
I think they should. I mean, if your nodes are negative and if your nodes are positive, I mean, definitely there has to be a change. I mean, that's very simple.
Definitely. I do agree, sir. If in this kind of scenario, I definitely would ask for an EBUS.
Okay, fine. See, listen, we need to. Not only already 7. Dr. Kumar, sir, 7:20 ho gaya. I need to go forward. Next slide, please.
10 seconds.
Sir, aap pura time dijiye, sir. You are the director everywhere. Tell me, sir.
My apology. Not only the field, it should show that it changes the outcome. And Savita will tell you that's the reason their group are doing 2 field versus 3 field, in spite of knowing that 20% patients has lymph node left out when they do 2 field. So ultimately, you have to see that outcome becomes different.
Okay, fair enough. Next one. So the conundrum is at present, let us say, Vamshi, if you see this patient, now let's go back to the earlier patient. You have discussed in the tumor board. Next one, what do you do?
So in N3, if it is like this, an N2, such a large volume,
N2, this is not an N3.
It's an N2 with such a large volume, I would actually kind of take a different path. I would actually suggest giving some NACT as well here.
Yeah, your point is there. We know when in doubt, give chemotherapy.
Exactly.
I mean, that's the typical take.
The last one, PDL1, I don't know what is the benefit of PDL1 in this scenario.
So right now, I think the presidential symposium at WCLC is showing that Adizo plus chemo is doing much better with PDL1 positive. It is there on Twitter, as Dr. Sabita said.
I have just one query.
Yeah.
Like Vamshi said that where to give NACT, yes, definitely, why not? I would like to ask the surgeons how comfortable are they in this scenario with the available data of NACC-RT?
So my question now is, what is the surgeon's perspective? So, this happens a lot of time. The surgeons and the radiation oncologists, they fight and then they say, ऐसा करो chemo दे दो, 3 साइकिल के बाद देखते हैं क्या करना है. So, Dr. Ramakant, sir, what happens? What does chemotherapy do? Is it like a breast cancer where we convert an inoperable to operable? Is it like we convert a MRM to BCS? Or what does actually NACT do? I mean,
no. Listen to me.
Don't say nothing.
There is nothing like inoperable becoming operable. What happens is, even in a large tumor in a breast, it is a pushing edge. It's not a completely infiltrated, complete breast which is infiltrated today. You're going to make it into a BCT tomorrow. It never happens. Yes. Understand one thing. If you have a 10 centimeter mass, it is a one mass which has actually pushed the breast tissue away. This shrinks, so the breast tissue actually goes back to its own position. That is exactly what happens. If the whole thing was actually infiltrating all into the 4 quadrants right in the beginning, you will never be able to save that particular breast.
So
okay,
when
so
the
this
medical
is this.
oncologist, so when the medical oncologist decide in the tumor board, okay, fine, let's give neoadjuvant chemo in lung.
Yeah.
Which are the patients you will actually want neoadjuvant chemo to be given? Which are the ones you say, yeah, nothing is going to make a difference. For the radiation oncologist, the field doesn't make a difference. For you, it doesn't change.
See, so that's what I'm saying. If your policy, if you believe in neoadjuvant chemotherapy, because see, if you give neoadjuvant or if you give adjuvant, the improvement in survival is only 1%, 5% versus 6%, right? So it is like that. So there is a benefit even in adjuvant chemotherapy, but maybe a little different, maybe a little less. But it's only 1% kind of a difference that way. So neoadjuvant is not the whole Vedic truth that what we
it's
look
not the
at.
holy grail.
No, it is not.
So which patients will you want neoadjuvant chemo to be given?
We normally as a practice, we do follow the practice of giving neoadjuvant chemotherapy. The whole thing is it has started in Tata Memorial Hospital because the patients were on the waiting list, and nothing better than to put a patient on a waiting list by giving him chemotherapy. Yes, it is. Well, this is the reality of the situation.
Ullas, can I make a comment? I think this whole idea of when we give neoadjuvant, it is not like a breast or somewhere where we want to see the response, we want to make BCS. It's more of a situation where surgeons are a bit uncomfortable because of the size or because of the nodal disease.
So that's what I'm asking.
That's what that the volume is too large. See, if the B20, B50 are okay and acceptable, I don't think there's much advantage of doing NACT before CTRT. So that I don't think there is.
Totally agreed. So Dr. Sabita, what I'm asking you is, forget the surgeons will always get the OTD. Let's say you have an OTD tomorrow. Or you are sitting over there, which is the situation for the general audience and uneducated people like us, will you ask us to give chemotherapy, and which are the ones you will say, I'll operate upfront? Simple question.
Ullas calls me for his panel only to make fun of me.
No, madam, make fun of myself.
The second point is the indications for giving neoadjuvant chemotherapy in lung cancer, the only one with evidence is proven N2 disease, where randomized evidence has shown that it has a benefit. The other two situations where we send our patients for neoadjuvant chemotherapy are if somebody has a borderline lung function and we think that with pulmonary rehab, this patient may get better lung function over the next 3-4 weeks, may be more suited for surgery, then we can start the pulmonary rehab along with neoadjuvant chemotherapy instead of making the patient wait and not giving anything at all. And a very rare situation where you think that the patient requires a borderline pneumonectomy and you want to not do a pneumonectomy but give the patient a chance, may get away with a lobectomy, but that happens rarely. Like Dr. Deshpande said, that the shrinkage of the tumor is not at the center, not at the hilum, it will always occur at the periphery. Yeah. So very few cases we may get a chance getting a lobectomy done.
Dr. Ullas, but one thing is, if you give chemotherapy while waiting for lung function to improve, your chemotoxicity might make him unfit for surgery. That is one thing we need to remember. It's not all roses. I mean, medical oncologists, we recognize that fact.
It's a gray area. It can cut both ways.
Yes. Yeah. You realize this, Vamshi, but you don't say it in an open forum. Kumar, your take on.
So I'm saying we'll give immunotherapy.
yeah, give immunotherapy. You can't try.
We publish the data on that. Majority of them, they do have a better lung function and they go for surgery. Sabita is here because we do know that these are the same patients, so she will tell you that no, they don't decrease the lung
Fair.
function. So
Sir, we'll go ahead. So,
but
Dr. Tejas,
we should not forget.
Fair. So, Dr. Tejas, does the neoadjuvant chemotherapy we give and then you give CT-RT, does it change the RT field? I'm sorry, I'm asking stupid questions, but these are the questions I need to know.
Yeah, no, sir, it doesn't change my field. But I just want to make a comment about NSCC versus NSCT versus NSCCRT. Except superior sulcus tumor,
there is no role. Okay.
There is no role of NSCCRT as such, sir.
So the surgeons, sir, somebody has given a pre-op CT-RT. How confident are you are happy with NACT or NACT-RT? Dr. Ramakant, sir.
Doesn't really matter. See, preoperative radiation or radiation therapy, the surgeon faces in two aspects. One is either it's a planned kind of a CT with RT, or there is a salvage kind of a case where patients have received, there's only a small disease left, but that is 60 gray or something like that, and then the patient comes. How comfortable are you while operating? Well, you can operate those patients, you can get a good clearance and all that, but these patients do take a little longer to come off the ventilator. That's number one. Number two, there's a little more oozing, but can they be operated? Yes, they can be operated. I don't think there's this thing. Where will you actually get worried about it? If you really seriously need a...
Dr. Deshpande, sir, we have just 5 more minutes. I mean, I think that also I'm overshooting. So can I go to the next one, please?
Sure. Okay.
Okay, I think we'll go to the next one. Just forget the endo. Just go to the next one.
Yeah.
Next one. Okay, so I think this is one thing which is always there. It's always a matter of perspective. You can have 4 6 or 3 6. We don't know. It depends on where you're looking at. But when in doubt between 3 and 4, give chemotherapy. I mean, just joking on that. Next one, please.
Do you think I feel very
okay, I think this is what the audience thought, and can we have the audience opinion on this? What is the right therapy selection? I think we'll just go next one. Just next one. Next one. Next one.
When do you become unhappy?
Next one.
It's
okay,
final
next.
exams. You're going to go to class 6.
Please go to the next one.
And from class 6, it will be school.
Next one.
No online. Khatam.
Next one. Please. Okay. Patient is now being counseled for CT-RT in the last 5 minutes. Just go to the next slides and I'll tell you when to stop. So the patient is counseled for any CT. Just stop over here. So what about the durvalumab? Suresh spoke a lot about durvalumab. What is your personal experience? What about PDL1? So what are the patients in which you will not give consolidation durvalumab? Can I start with you, Vamshi? So the patient has got CT-RT.
Yeah,
and
where you would not give is where you have lung function that is impaired, where you have where the response is not good. Patients with post 6 weeks is what the trial has taken as a cutoff in practice.
I think can I request all the audience to yeah, okay.
Dr. Sahu no. Dr. Sahu's mic is on.
I know, but I didn't want to say that. He's my senior. Okay, Tilak.
Yeah. So patients who had a very good response to the chemotherapy, especially in N2 disease, I think we'd like to consolidate with durvalumab, and the patients with a good functional status thereafter and after the CT-RT, who have reasonable systemic functions.
Fair enough. So I think there is no doubt about the efficacy. Can I get Dr. Suresh in? Dr. Suresh?
Yeah.
Are you there? Yeah. Suresh, there was some data about PDL1 negative. I mean, I think we're going to give it to everyone, people who have not progressed following CT-RT. What about PDL1 negative? There's a lot of doubt about that. So somebody with a PDL1 0 or a biomarker-driven lung cancer, would you ask for consolidation durvalumab, the medical oncologist in the town? Suresh.
So if we go by evidence, the subgroup analysis shows that it is effective irrespective of the PDL1 status. But if you go into the nitty-gritties, then definitely the volume of benefit is lower in the PDL1 low population. Okay. So going by evidence, yes, I would give.
So would you? So I have two subsets for you: a women, non-smoker, NACLC, CT-RT given, EGFR mutant, PDL1 0. You would give durvalumab, you will not give durvalumab. Just say yes or no, Suresh.
Ideally,
you are the one who prompted me into this. Tell me yes or no.
I wouldn't like to give durvalumab. Okay.
You would not like. Fantastic. Vamshi.
Yes, I would give still.
You would still give.
But next year I may change my mind when I get data.
Yeah, you can always change your mind. The lawyer is going to sue you over there. That's absolutely okay. Change your mind later on.
EGFR mutant, I'll hold on.
EGFR. Dr. Kumar, sir, your word. NSCLC, CTRD, EGFR mutant, PD-L1 negative.
Yeah, they do badly. That is true. We analyze our data also that most of the patients who failed early were those mutation positive.
Okay, and I think Suresh also did show some slides about starting them. The ideal benefit is seen within the first 2 weeks, but actually the benefit can be seen if you give it beyond 6 weeks also. There's a data with Suresh. So can I just go to the next one, please? Two more, next slides. Next one. Next one again. So Dr. Deshpande, sir, this is the benefit of immunotherapy. This is just to tell the advantage in stage 3A disease that the immunotherapy is also doing now, sir. The OS and the PFS advantage, sir. The graphs are just different, sir. Next
yeah. No, I understand that. And if PD-L1 is positive, even more than 1%, some of my patients are on this treatment. So
next slide, please. Next slide. I think, okay, fine. Next slide. Just show me the last slide now. Just one more slide. One more slide. Yeah. So one more slide. One more slide. Okay. So this is the data that Vamshi was referring to, which, the last one, if you say if the PDL1 is less than 1%, placebo was supposed to be slightly better. But again, this was a post-hoc analysis. This was not a pre-plan analysis. That's it. This is just one I wanted to show. And thank you all for a wonderful discussion, and hope to meet you soon. Thank you. And I hand it back to the organizers. Thank you.
Thank you. Thanks. Bye.
Thank you.
Thank you. Thank you so much,
Thank you, sir.
Dr. Ullas Batra, sir, and all the eminent panelists for the wonderful brainstorming discussion. Now, moving ahead, I'd like to invite our next chairperson, Dr. S. Vishwanath, who is a consultant medical oncologist at Apollo Hospital, Bangalore. Over to you, sir.
Yeah, thank you so much. And at the outset, I would like to thank the organizers for giving me this opportunity to chair the session. I think in the last decade or so, we have seen a paradigm shift in the treatment of metastatic lung cancer, and especially in EGFR mutated patients with the EGFR blockers, which have stood the test of time, and with PFS benefit, and more recently the OS benefit. I would like to invite our moderator, Dr. Kumar Prabhash, the head of Department of Medical Oncology at Tata Memorial Hospital, to moderate this case-based discussion on a very important topic on critical factors to consider in the treatment of EGFR mutated non-small cell lung cancer patients. Over to you, sir.
Good evening, everyone, and we have a wonderful panel of people. We have medical oncologists, traditional oncologists, and surgeon, Dr. Ashay, Dr. Ashok, Dr. Anvesh, Dr. Amit, Dr. Devyani, and Dr. Nandini. Maybe we can start with the panel. We can have the first case. Can you change it from here? No, I'm not able to. So can you change it from there? So 45-year-old lady, housewife, had dry cough, chest pain, and breathlessness for around 3 months. The cough was there, and chest pain was for a month, and the breathlessness for 2 weeks. Next slide. Examination, ECOG was good, pulse, vitals were maintained, respiratory rate was on the higher side. There was a decreased breath sound on the right interscapular and infrascapular and memory region. Percussion note was dull, and there was no other finding. Next slide. These were the investigation which looked good, and for the CBC and biochemistry. Next slide. And we did a CT scan was done, and it showed heterogeneously enhancing lesion approximately 4 into 2.5 centimeter, multiple irregular heterogeneous enhancing pleural deposits, and right pleural effusion, which was obvious on the CT scan. No pericardial effusion. There was hypodense lesion on the liver, suspected mets, no adrenal mets, and skeletal. There were no mets seen in the bones. Next slide. Patient underwent ICD insertion, and there was a fluid which was drained. Cytology showed metastatic adenocarcinoma. IHC was done, which showed CK7 positive, TTF1 positive, and P53 mutation type, which was positive. Negative for CK20 and CDX2, negative for ALK amplification on IHC. Next. Molecular test was done, which showed EGFR positive on RT-PCR, which is done at our center, ALK IHC negative, ALK fish uninterpretable, ROS1 fish not detected, and MET fish not amplified. Next slide. This was the report for EGFR. Maybe we can go to the panel. What more information you want in this report, or is it good enough? Don't go by what is there. Wild type, it is basically mutant exon 19, which is there. That's the error. I can take it from anyone. Dr. Ashay, do you want to comment, or this report is good enough, or you want more details? Dr. Ashay is there? If Dr. Ashay is not there, maybe Dr. Anmesh.
So Dr. Amit Ratan is also part of the panel.
Sorry, Dr. Amit Ratan is there?
Yeah. Hi, Kumar. Hi. Thank you. Yeah. So I was just trying to interpret the report. I couldn't get it. Is it exon 19 deletion present? And
Yeah, exon 19 deletion, and that wild type is the error there. So it was the exon in-frame deletion which was positive. You want more information?
Yeah, but it says T790M also present.
Yes, that is true.
So we have a diagnosis with a T790 from the start. Now, this is a very, very rare presentation, and this maybe we should have to do a T790 germline testing also for the EGFR. This is kind of a pretty rare presentation.
Dr. Ashay, any more information you want, or this is good enough? In today's time, you say no, we want better technology to have more information.
Yeah. So basically now many of our patients are going for NGS actually, sir. Because PCR we have actually only specific, like whatever the specific probes which we use. So accordingly we can get, but in NGS we might have some uncommon mutations also which can be seen, plus some additional mutations besides, like if we have MET or, sometimes when KRAS is there along with the EGFR. So that also can affect the outcome in addition to the EGFR.
Dr. Nandini, any comment from your side?
Sir, NGS could detect additional mutations, but if there is both T790M and exon 19 deletion, it's a rare thing to have upfront T790M. So it also means that it is probably not going to respond to the first generation TKI. So it will have an implication on the therapy what we give the patient.
So there are very important issues raised by different people. One was that you have T790M. Is it germline or it is somatic? That becomes important, and we won't know unless we have done quantification of those mutations in NGS. That may help us. Second question was raised that in exon 19, by and large, we take it because we do RT-PCR, we take it, they are sensitive mutation, we are doing specifics. We want more details, which type of exon 19 mutations, in-frame deletion we have. Then it is again important that we have those NGS technology which can give us those important information. So these are important points raised, but till recently we have been comfortable with this the reports, and we have been managing, but I do concede we will require more information as the time goes by. And just for the audience, in case if you do NGS and your allele frequency is pretty high, it is something like 50% odd and beyond in T790M, there's a good chance that it can be germline, and it's important to test that does it predispose the patient to some familial kind of cancers. So that becomes important. Very uncommon, but it does happen. We have seen in our clinic. So it is good to have additional information. But for routine care, I can see this information is fair enough for us in deciding a routine treatment. but as the time goes by, we will be requiring more. Next slide.
Kumar, just so just one point. You had a P53 on the IHC, so
Yeah.
that's one thing we'll definitely need to see on the NGS.
Yeah. So P53, again a valid comment. P53 is the commonest somatic mutation in lung cancer, and almost 80% patient has it. But the moment you have T790M and with P53, you do get concerned. Are we missing something? So your point is absolutely valid. When you're seeing unusual, you do start feeling that are we missing something beyond the routine what we see? That's what the point you wanted to make.
Yeah. So in this we are talking of T790, but if we didn't have a T790, then having a concomitant P53 sometimes may make a change in treatment sometimes.
Okay, I take your point. I take your point. In this situation, so if you have P53, again, if there is some family history, we need to be suspicious. Go to the next report. This is the report of ROS1, and this is the report of ALK1. Anyone wants to comment on these reports? Good enough, or we require, and this is from Met. Maybe we can go back to ROS1 and the ALK.
Yeah.
Is it good enough, or we require something more in this? Maybe we can start with Dr. Asha.
So ROS1 fish is acceptable. So means for the ROS1 especially, but ALK1 I think IHC is more reliable, and there is good concordance. But I think this patient by IHC ALK1 was negative actually. So the thing is that even in the trials where ALK1 has been used, I mean the IHC where they are positive and fish was negative. They have found that, but if the reverse was true, like they are negative by IHC but positive on fish, they really didn't do very well on ALK1 basically. So in ALK1, IHC is good enough. Maybe I mean there is good correlation between the fish and IHC.
Dr. Amit, any comment?
Yeah. So for ALK, if we get a fish negative, but we still should do the IHC, we'll pick up some more of them as positive. In ROS, what we are seeing is many of the labs are starting to do IHC, but there we have to be very cautious. If it's IHC negative, we should still, or if it's IHC positive, we should still confirm by fish. So in ROS, we'd want a fish.
Totally agree. Dr. Nandini, anything to add to this?
Yes, I agree with what is said. The ALK is negative, even though fish is uninterpretable, ALK IHC is negative, so we have ruled out ALK, and the ROS is negative for fish, so I think ROS is also ruled out in this patient.
So it was a very important comment. If you have ALK IHC, it is good enough. If your lab has validated it, you may do certain other tests. It adds some, but not much. Maybe IHC may pick up more than what you get picked up by a fish. ROS1, be careful with IHC report. Fish is important, or NGS is important. Only IHC, unless your lab has done a validation work and shows the good concordance. Our lab at TMH has shown an excellent concordance, so we depend a lot on them. But having said that, that's an exception. They use a different antibody than routinely what is used, so be careful. Next slide.
Can I comment on this, Dr. Kumar?
Go ahead.
Yeah, sir. Ullas here, sir. I am from Rajiv Gandhi, sir. So,
Ullas, please go ahead.
So we are also doing ROS screening by IHC, sir. That is, again, I spoke with our pathologist, and what they're saying is that because fish is a very labor-intensive process, and a high volume center, if you keep on doing fish, you might miss some of the signals over there. So only if you, so once we have IHC positive, then we go ahead and do only those positive people, and we do a fish confirmation. The reason why we are doing IHC screening is this.
Agreed, Ullas, and I totally agree with you. This is the one good approach of ensuring that more patients you are able to do molecular tests.
Yes, sir.
Kumar, can I ask a question?
Go ahead.
So if you are doing NGS directly, and if you don't pick up a ALK and a ROS, do you go back sometimes thinking you missed it and want to do an fish or
Can I come on this, Dr. Amit? Yes. So we have recently published, I think in the process of publishing our data, I think we had, so we took IHC as the baseline for ALK, and we also got NGS done, and we also got fish done. So if you have 100 ALK positive, fish was positive only in 76% of people. The rates in Western literature are around to the tune of 85%. Our NGS rate positivity actually is only 83%. So I would totally agree with you. I mean, now that we are moving towards NGS, I have told them for the first 1 year, I would definitely want to do ALK by IHC just to be very, very sure. Till the time our learning curves are almost gone. So that's the take that we have. And so there is a 16% things which we missed on NGS. I don't know how.
So we all, yeah, right.
We do. I agree with you. So anyone wants to else to comment? This is something important to remember and realize when we do in clinical practice. See, the moment you do test, if you don't have a resource constraint at all and tissue constraint at all, if you keep doing tests by different method, by some method you will pick some extra from the routine ones. For example, IHC, FISH, and NGS. You will pick some extra by one method over other. There will be relatively anecdotes, but it does happen. I have seen by each method. There are various reasons to it. At this moment, I know we won't get into the details why by individual method you sometimes pick and sometimes lose. But we know that in practice, ultimately you have to choose one or maximum two methods, preferably one method. One of them is good enough, what we know. So if you're using NGS, going back to do another one is maybe I'll wait for some time the way Ullas said to see how the NGS is working and then only use only NGS. But once I start using it, showing my concordance, I will not go back. Do I get once in a while patient who says, please do everything? Yes, go ahead. Then we do all kind of things, and usually, one way of doing gives you a fair answer. So, Amit, if you're doing NGS from a good lab, you can be comfortable. Like thermofish standardized methodology, but again, they need to share the
right.
Hello.
concordance for your ALK and ROS and maybe MET, and then okay, that's good. Coming back to the another report, MET, good enough, or we want more information? Amit?
No, I think so. So MET, if we are doing a fish, we are picking up only the amplification, and we know at presentation the MET mutations are more important. We are looking for the skip mutation, so I think we need the NGS here. I don't think we can go for the fish in the initial part of it.
I totally agree. Any other one has any other comments? So
basically, exon 14 skipping mutations MET are there. They usually have a poor prognosis, which can be there into almost 1 to 4% of the patients. So I think that is one of the most important thing we should know when we
so
start.
these are the initial patients we used to do this, and this is not good enough, and that's the take-home message to remember. Next slide. These were the scans. We can simply go through the scan. Next slide, please. Next slide. Next slide. Next slide. We do have just 5 minutes. And next slide. Next slide. Next slide. Next slide. Yeah. Tissue biopsy. Dr. Devyani, how do you choose it, and where you want to do it from?
Actually, sir, like you mentioned, this patient had a pleural effusion that was drained, and we had enough fluid to give us a positive cytology. If we get a good enough cell block from that pleural fluid itself, we can usually run most of our molecular markers on that as well, and that should suffice. But in case the pleural fluid comes negative, then the primary lung site for a CT guided biopsy would be my choice if she does not have a supraclavicular lymph node. Or you mentioned this patient had a liver met. So we would like to characterize the liver met by an ultrasound. If it's a large enough met, then that would be, I would choose that for a biopsy over the lung because the complication rate would be lower.
If lung lesion becomes tough to target and liver is nothing in liver and fluid is negative, should we go in the pleura and get tissue, and how easy it is?
It's not, it's a, whatever you say, it's a procedure under general anesthesia. But I think in the situation that you mentioned that no other sites are yielding a biopsy, then I think that would be the only option that we would be left with. So then that
we
would
get a good tissue and it's safe.
Sorry, sir?
Yeah, it is safe and we get a good amount of tissue there.
Yes.
So that's again an important take-home message. Find out the tissue where you get from, and one of them is if you have pleural deposit, many times you don't get adequate malignant cells. Then putting a scope and getting this tissue is not tough. Experienced hands like Dr. Devyani, and you will get it is a safe procedure and you can get adequate tissue. When would you do liquid biopsy upfront? Amit?
So I kind of look at it this way. If I have getting tissue, I will definitely chase tissue. But like your patient is 45-year-old, and if my tissue comes negative for all the routine tests, I kind of end up doing a blood NGS definitely. Or secondly, if we are clearly sure not getting tissue by any reason, then I send blood NGS. But the problem with liquid biopsy has always been platforms, discussions of which is a reliability test, validated test. So that becomes the major issue. But we are doing more and more of it. So there's many situations now we are doing both just to see how the concordance comes in, and we are doing quite a lot of both in our settings. Though I know it's not practical, it's not what we should do.
Okay. Thank you, Dr. Amit. Next. Any scan-wise, any limitation we have? We do MRI in all of them, Dr.
Yes,
Nandini or Dr. Ashay?
Yeah, so MRI brain only when I'm planning a targeted, if we get some targeted mutations. So now we have, especially in EGFR or even ALK, we have plenty of options. So basically set us on brain mets, whatever is there at the baseline. So I think MRI brain definitely we should be doing, even in the asymptomatic patients if we are planning for any targeted therapy, basically.
Okay, so now we are doing it more and more as the time has gone by, but in the past we were not, and primarily because we do have more brain mets in these patients, like with having EGFR or ALK. Next slide. If a patient with metastatic non-small cell lung cancer has no CNS symptom, would you like to do a brain scan? And we'll see the result later on. Next slide. There was a poll. Next slide. And this is just to show that the kind of recommendation you have, and the way it changes, the more therapy you get, the recommendation will start changing. Next slide. Next slide. This is regarding wait for the report or start treatment. Dr. Nandini?
So if the patient is stable and is not very breathless and is able to come for regular follow-up frequently, like maybe every week or every 4 to 5 days, then we usually wait for the mutation testing report. But in a very dysgenic patient who is clinically very symptomatic with a large disease volume, we would start off with chemotherapy first so that we don't lose the window of opportunity of treating the patient, and probably change the therapy based on the molecular testing reports once it's available. But in a patient who is very minimally symptomatic, we probably would closely follow up within a turnaround time of 1 week, and then probably start treatment when the reports are available.
Then we should have Omshi on the panel for 1 week when you say to get the...
Yes, sir, that is only the challenge. But if a patient is very sick or symptomatic, then we would prefer to start chemotherapy before the results are available.
So maybe we can, Dr. Ashok is there?
Yeah, I think he joined after.
Okay, Dr. Ashok, in case the patient has a brain mets or bone mets, or patient has a chest pain with, because of the primary tumor, and we don't have a mutation report, do you want to give this, radiotherapy now or later or in between or with the systemic therapy?
Can you please repeat, sir? My connection is slightly poor today.
Okay, I'll repeat again, sir.
Sir.
If the patient has a brain mets or bone mets or lung lesion causing chest pain, when do you want to give radiotherapy? Before systemic therapy, after systemic therapy, in between systemic therapy?
Sir, if I understand correctly, the question was if the patient has a brain met or a bone met or a lung lesion, which is when to start the radiation in before systemic or along with systemic therapy. I think AGFR mutation status obviously has a radiosensitizing effect with the radiation. But if the brain met is there, I would like to start the palliative radiation upfront. Bone mets, if there is a bony pain, for palliation of pain, we should be giving it upfront with the hypofractionated doses. That would be my take on it, sir.
Okay. Next slide. So these are when you want to start in between, you can, and then you can change the treatment after report. Next slide. Next slide. Next slide. These were those, all the factors which we, think about before choosing treatment. Anyone wants to prioritize it? Amit, do you want to prioritize it based on what you see here?
Yeah, so I think, yeah, with nowadays the mutational status and the type of EGFR mutation comes really up there, because sometimes even with poor performance status and irrespective of age, you can really get patients responding. So I think I'd really put that right on top. Of course, again, cost is another major factor which will play in. I think that those are the main things I'd move upwards.
Okay, next slide. Just showing the result. These were the, so all over the place. Next slide, please. Next slide. Treatment options, not necessarily go by what you are seeing here. I know we can start with Ashay. Maybe last two questions we'll close it then.
So for this patient, even chemo plus TK, we have a very good data, like PMH data only, sir. So because she's a good performance at this young lady, so PEM carbo along with Jeff is another option. But I think she's T790M mutation also. I think this lady is.
Okay.
So again, has to be a choice here in this patient. If there is no T790M, then chemo versus chemo plus TKI. Again, there is also data in the first line if those who cannot even go for osimertinib, because now bevacizumab we have a lot of generics. So erlotinib plus bevacizumab also remains a choice, but again not in T790M mutations. And we can always have a debate, whether to go for sequencing, because there is a data of hepatinib followed by osimertinib, which is also there showing a very good OS, which is almost nearing to 4 years. So I think now there is options of plenty. But if this lady especially will choose osimertinib because of T790M mutation, if it is really proven that it is significant.
Dr. Amit?
Yeah, I think the best choice for her would be osimertinib first line, no doubt.
Okay. Nandini?
So same osimertinib first line, and if she is not able to afford osimertinib, then maybe chemotherapy.
Chemotherapy plus TKI. Ullas?
Any generation TKI, sir.
Sorry?
Any generation TKI, sir.
Okay, okay. And no, so we do understand we'll have those options. There are 7, 8. We'll choose one of them. We got the view from the panel. And the last question to our surgical colleague and radiation colleague: consolidation surgery or surgery for oligoprogressive disease? Devyani.
Not in this case, I'm assuming, sir.
Excellent response, and then one new nodule on the opposite side.
If that's the only site of disease and she's responded well everywhere else, then
after 2 years, patient comes with one new nodule.
Definitely worth a shot, sir.
Worth it. Good to hear that. Ashok, Dr. Ashok, consolidation RT after excellent response, some residual disease, 2 centimeter left.
2 centimeter disease, we should go ahead with SBR, sir.
SBRT?
Yes, sir, SABR, sir. Less than 3 centimeter, I think that is proven efficacy these days, sir. Rather than going into different surgery, SABR has equally proven to be effective in less than 3 centimeter disease. Excellent response. EGFR mutant positive. I think we should go ahead with SABR with high doses.
Oligometastatic disease on the opposite side after 2 years, 2 centimeter lesion.
I didn't get you, sir. I'm sorry.
So one was consolidation RT after good chemotherapy response. Second situation, I'm saying the patient was doing good for 2 years. Now there's a new lesion on the opposite side.
Size of the lesion, sir?
Around 2 centimeter.
Again, sir, SABR. I would suggest SABR should be the treatment of choice rather than surgery.
So we will be seeing this more and more in our clinic, and more and more we need to interact with.
Where was Sahuyer?
Sorry, go ahead, please.
I just want to ask one question.
Please.
Is there any hardcore data for a concurrent T790 mutation upfront for osimertinib first line? Or are we can we just go the way that we give chemotherapy and a first generation and reserve osimertinib second line? I don't think there is any hard level evidence. What would be the right way? Because I don't feel there is some very small data of osimertinib in such setting. So are we just extrapolating just because T790M hai, humko osimertinib hi dena?
Hi Ullas, let me bounce the question to you.
Okay, so the incidence of de novo T790M mutation, even with the ddPCR, is not more than 3 to 4%. Typically, sir, Dr. Sahu, I mean, looking at the second line data of T790M, if cost is not an issue, we would want to give osimertinib. But a chemo plus TKI combination will also be absolutely okay in this. Because there's a T790M clone, I'll be less reluctant to give, less likely to give first or second generation TKI. That's my take. But there's no hardcore data.
The same. The way I read the data, if there's upfront concurrent T790M, it is osimertinib is not that active as we get in the mutational setting in the second line. So
the numbers are too small. I mean, I don't think
that's the question which I thought is the best forum to ask. And let me hear something, because I'm really not convinced about the first line data in the concurrent setting.
And the multiple mutation.
So Dr. Kumar, your last word. And don't be diplomatic. Just tell.
So in this situation, if I am allowed to choose, and sure we'll all keep discussing, but till I'm comfortable with the patient that I will be able to expose to the second line treatment, I'll prefer TKI plus chemotherapy, because we have used that in multiple setting and we are comfortable with it, because we know that it will be able to handle multiple clones, whatever we have there, and we have less worry about it. Only we need to be a bit careful that we are not missing T790M, where we are not able to expose the patient in second line.
So, Dr. Kumar, I have two comments for you. In your data, when the data which आप लोगों ने present किया था about EGFR and TKIs in chemotherapy, have you gone back and done NGS for them to find out how many of them had coexisting mutations?
Ullas, you want to always give me tough,
Questions are always tough. Answers आपके लिए तो बाएं हाथ का खेल है, sir.
Who is going to do NGS for me? Ullas, unless Rajiv Gandhi agrees, tell me. But your question is very valid. Ullas asked a very, very valid question. We have all those DNA, with the lab.
Sir, do you have? I'll be happy to. Actually, I've got funds. I'll be happy to do that, sir.
Oh, excellent.
Honestly.
Absolutely. I take that proposal.
Okay. The second question is here, sir. What about the role of TKIs in oligometastatic NSCLC upfront? Now, somebody has got a lung mass, some N2 lymph nodes, and one adrenal lymph node. Adrenal mets is there, proven. What is your take on TKIs as neoadjuvant setting in EGFR mutant? Your take. You're the final word.
And subsequently, you want the local treatment as a plan, isn't it? See, N2 disease, I have no doubt systemic therapy needs to be given first. Absolutely. Whichever, we can keep debating. It should be chemotherapy with TKI, only TKI. We can debate on it, knowing that TKI have a higher responses. And sure, I will love to have some local treatment for it, because you want to call those removing the disease, whatever is left out. So it reassures from the previous data that you have 1/3 of the patient disease not coming back. But neoadjuvant, exposing to systemic therapy, no doubt for N2 disease. Here is N2 disease plus M1. No, definitely. The tricky one will be if Devyani tells me, Kumar, it is T2 and adrenal. Now what do I do? No, that's a tricky question with EGFR mutation positive. I will only request Devyani, please don't do EGFR in these patients before surgery.
We've had that situation recently, sir.
Yes.
Operate both.
So with this, we had a nice discussion, and I thank all the panelists, and thank you so much. And with this, I close the session. We have gone beyond the session by around 15 minutes. Thank you so much.
Thank you, sir.
Thank you so much, sir.
Thank you, sir, and all the panelists for the wonderful discussion. Now moving ahead, I'd like to invite our next chairperson, Dr. Pradeep Kumar Jaiswal. He's presently working as a DPMO at Western Air Command, New Delhi. Over to you, sir. Dr. Pradeep Kumar Jaiswal, sir. Sir, you have to unmute yourself, sir.
Yeah. So am I audible now?
Yes, sir.
Yeah. So good evening to all panelists and the speakers. We had an excellent discussion on targets, platforms, and targeted therapy of non-small cell carcinoma lung. So after that, now we will cover the second type of carcinoma lung, which is more aggressive, less common, extensive SCLC. And to speak on that, we have Dr. Advaita, who is a senior medical oncologist at Prince Ali Khan Hospital in Mumbai. He will be speaking on emerging immuno-oncology strategies for first-line extensive stage SCLC. Dr. Advaita, please.
Good evening, colleagues. I am Dr. Advait Gore, medical oncologist from Prince Ali Khan Hospital, Mumbai. And at the outset, I would like to thank Dr. Kumar Prabhash for this yearly meeting for where we discuss about newer developments in lung cancer. And my job today is to discuss about the emerging immuno-oncology strategies in first-line extensive stage small cell lung cancer. Over the next 15 to 20 minutes, I would go through what is the rationale behind using these and what is the current data and what are the drugs which are approved in this indication. So starting off with the history and background of small cell cancer, we know that high-grade neuroendocrine carcinoma and small cell lung carcinoma has a huge metastatic potential. When we look at the US data, about 13% of lung cancers are constituting the small cell lung cancer group. And we also know that there are common genetic alterations in the P53, the RB1 inactivation, and there are no clearly targetable genetic driver mutations which have been really isolated in this. For many years, a combination of platinum with etoposide or platinum with irinotecan has been the standard of care. We know that these diseases do respond to almost close to 70% patients do respond to these lines of treatment as an initial therapy. But we also know that almost half of our patients do relapse within a short period of time. When we look at the Indian scenario, small cell lung cancer accounts for about 15 to 20% of all the newly diagnosed lung cancer cases, and about 70 to 90% variable data sets from AIMS, from Tata, from Adyar Cancer Institute have shown that about 70 to 90% of patients do present in extensive stage. Most of us for limited stage disease look at concurrent chemoradiation as a combined approach. In extensive disease, it's essentially palliative chemotherapy where patients have a poor survival. There are Indian studies, study done by AIMS, about 85 small cell lung cancer patients, 34 with limited stage, 51 with extensive stage, and we have a median PFS of this entire cohort of only about 11.4 months, and this is with chemotherapy alone. The Adyar Cancer Institute Chennai has similar data with median PFS in patients with extensive stage of 6 months and a median overall survival of a dismal 7.2 months. Now, how this systemic treatment in small cell lung cancer has evolved, we've seen that from the 1970s, where there was an alkylator-based treatment, to the 1980s, where anthracycline-based chemotherapy became the standard treatment. And from the 1990s till today, there weren't much development in treatment of these extensive stage small cell lung cancer. So platinum-based chemotherapy was the standard of care. As I discussed earlier, it is etoposide and irinotecan based. And what today I tend to look at is what is going to be the role of checkpoint inhibitors, either a single agent or as combination in treating this disease. Historically speaking, the etoposide platinum combination showed that there was a rapid response and a dramatic response. About close to 60% patients do show responses. However, these responses are short-lived, and most of the patients within 4 to 6 months have progression. We all know that small cell lung cancer is initially a chemosensitive disease, but many of the patients, almost 50% or more, do relapse with a median progression-free survival time of somewhere between 4 to 6 months following standard first-line treatment. Most of these patients live less than 1 year after diagnosis, and improving the durability of response to this treatment actually remains very critical in extensive stage small cell lung cancer. We also need treatments which can extend survival for more patients, and we also know that there are about 10% of patients who do present with asymptomatic brain metastasis, which naturally confers a poor prognosis to this subgroup of patients. Coming to the rationale of combining immune checkpoint inhibitors with chemotherapy in this indication, we need to go back and assess as to how self antigens actually can become tumor antigens. We know that cancer cells possess genetic alterations, or they perform post-translational modifications to create neoantigens which are recognized by the immune system. The mutation and the post-translational modifications have been shown in these charts, which was published by Finn et al. In NEJM 2008. Small cell lung cancer, we know, has a high tumor mutation burden. We see a median of 7.37 mutations per megabase in this disease, and this has been well studied. Hence, there is a biological rationale for immune checkpoint inhibitors to be used as anti-cancer therapy. We know that anti-CTLA4, they essentially look at blocking the inhibitory signal by antibody binding. In the priming phase in the lymph node, there is activation, and then there is an effector phase, tumor microenvironment. We have the activated T cell, the tumor, and the T cell rearrangements. The anti-PD1, Nivo, Pembro, Avelumab, and Semipilimab. The anti-PD1, PD-L1, the Atezo, and the bevacizumab, they essentially have negative regulation which are blocked by antibody binding. So when we look at the rationale, we know that chemotherapy induces tumor cell killing. Now this tumor cell killing induces tumor antigen release and exposure to the immune system. PD-L1 overexpression leads to immune evasion and T cell inhibition. In terms of PD-1, PD-L1 inhibition, the PD-1, PD-L1 inhibition restores this tumor specific T cell immunity, and then there is reversal of immune suppression which leads to deeper durable systemic anti-tumor responses. So looking at the key studies of immune checkpoint inhibitors in small cell lung cancer, there have been multiple studies done right from 2015 till May of 2020. Many of them have been published in literature. Initial studies looked at ipilimumab with chemotherapy, then the Checkmate 032 where Nivo-EP combination was used. In June 2017, Pembro maintenance was evaluated, and all different drugs have been evaluated in various phase 2, phase 3 studies. What I'm going to discuss essentially are these four: the IM Power 133, the Caspian. We look at the EA 5161 data as well as the Keynote 604. Phase 3 trials looking at addition of anti-PD-L1 checkpoint inhibitors to first-line platinum etoposide. We have two of these studies, IM Power 133, which looks at patients with extensive stage small cell lung cancer with no prior treatment, those who have been randomized to receive atezolizumab with EP combination versus EP alone, and patients received 4 cycles of this as induction followed by maintenance atezo until disease progression. When we look at endpoints, overall survival, PFS as a co-primary endpoint, secondary endpoints of response rate and duration of response. The Caspian study, which looked at 3 different arms, Durva, Tremi plus EP, Durva plus EP, and EP alone. Here the number of cycles for the Durva, Tremi, and EP arm as well as the Durva and EP arm were for 4 cycles, and EP chemotherapy was given for 4 to 6 cycles. Maintenance treatment with the targeted agents and PD-L1 continued until disease progression. These are the data from Caspian study. This is the updated objective response rate in the Durva with EP arm, where we see that the combination of Durva plus EP gives rise to an overall response rate of about 68% as compared to EP, which is just 58%. And when we look at proportion of patients on the x-axis, in the y-axis, and time from confirmed objective response rate, here we see at 12 months, about 23.2% of patients who are on the combination arm as compared to 7.3%, and at 24 months about 13.5% versus 3.9% patients showed confirmed objective response. This is the slide of the updated progression-free survival in the Durva EP versus EP, and PFS was actually not tested for statistical significance. 56.8% patients in the control arm received 6 cycles of EP as compared to only 4 in the combination of Durva plus EP arm. When we look at the number of events and the median progression-free survival, we do see that Durva plus EP, the number of events are in 234 out of 268, almost similar, 87%. Median PFS is 5.1 months versus 5.4 months, hazard ratio of 0.8. When we look at landmark PFS percentages at 6 months, at 12 months, 18 months, and 24 months, we clearly see that beyond the 6-month mark, these curves are separating, and at the 12-month mark, it's 17.9% versus 5.3% of PFS benefit, and at 24 months, it's 11% versus 2.9% in favor of the Durva and EP. When we look at the overall survival data of both of these studies, the IM Power 133 and the Caspian, we see here that the atezo containing group, the median overall survival is 12.3 months versus 10.3 months with the chemotherapy arm itself. And we have a hazard ratio of 0.76, 12-month overall survival of 51.9% in patients who are receiving the combination therapy versus 39% for the chemo-only arm, and 18-month overall survival of 34% versus 21%. The Caspian data also shows that adding durvalumab to chemotherapy showed improvement in the survival. Again, similar figures of about 52.8% at 12 months versus 39% with the chemo arm, 18 months 32% versus 24, and we see here that at 24 months it's 22.2 versus 14 months, favoring the durvalumab addition. It's difficult to do a cross-trial comparison, but we are looking at these figures. When we look at the atezo durva, we see here that the median overall survival of 12.3 versus 10.3 in the atezo, 13 versus 10.3 in the Caspian study. A median PFS is slightly improved with the atezolizumab. Similar with the Durva, overall response rates varying between 60% to 67%, favoring the addition of immune checkpoint inhibitors. Not much of a difference in grade 3 or higher toxicities, because immune-related adverse events, we see here that they were more in the atezo group as compared to the Durva group. This was presented as an ASCO abstract in 2020, where addition of anti-PD-L1 checkpoint inhibitors to first-line platinum etoposide in extensive stage was evaluated, looking at 2 other drugs, pembro addition to chemotherapy. We see here median overall survival 12-month rate, again 45%, slightly lesser than the previous trials, which was 52-54% there. 39% remains the standard with the EP arm. 24-month rate almost similar across all the previous studies, about 22.5% versus 11%. Adding nivo to chemotherapy, we see median overall survival of 11.3 months with addition of nivo as compared to 8.5 months with the chemotherapy alone arm. So summary of all these trials, where we have evaluated frontline chemoimmunotherapy combinations across all these studies. When we look at what is the overall response rate, there is definite hike in the overall response rate. We see here with the chemotherapy arm on the left and the chemo plus IO combination, there definitely is improvement in the overall response rate. PFS rates are also improved in certain studies. We know the hazard ratios are also favoring that, and the median overall survival, when we look at these figures, they also show that there is improvement. So in summary, when we look at these forest plots, chemo plus immune checkpoint inhibitors, when we look at the IM power 133, the Caspian, which is just the Durva arm, the Durva Tremi arm, the Keynote 604 and the EA 5161, we see that in terms of overall survival and in terms of progression-free survival, the combination of immune checkpoint inhibitors with chemotherapy does show that there is definitely a benefit. This benefit has also been endorsed by NCCN guidelines for 2021, where the preferred regimen for patients who are having extensive stage small cell lung cancer, the NCCN does mention both these drugs, the Atizo plus etoposide carboplatin regimen, which was there in the IM Power study, as well as the Caspian protocol where Durva and EP was used. So in summary, we know that addition of these checkpoint inhibitors to platinum etoposide based chemotherapy has significantly improved survival. We have data to support the use of these drugs in combination with chemotherapy, Atizo on basis of the IM Power 133, Durva on basis of the Caspian study. There are encouraging results with Nivo and Pembro also in combination with chemotherapy. These are in the form of the phase 2 study for the nivolumab, the EA 5161 study, and the phase 3 Keynote 604 study for the Pembro respectively. Safety outcomes are consistent with the side effects that we've known and managed in patients who have received immune checkpoint inhibitors, thus making combination therapy a new standard of care for first line treatment in extensive stage small cell lung cancer. Thank you very much.
Patient 62-year-old gentleman, chronic smoker for 30 years, no comorbidities, and then he had presented with a dry cough of recent duration, generalized weakness of recent duration. There was no CNS symptom in the form of vomiting, headache, and seizures, and he had a very good performance status ECOG 1, and then he had no supraclavicular lymph node. Systemic examination was normal. Effort tolerance was first floor, he could go on. And next slide, please. So he was investigated, and the CT scan, you can see all the masses over here. The mass was in the left upper lobe lung, invading the pleura, and then also the infiltrating the hilum and impinging on the left pulmonary artery. Next slide. And so that's the mass. Next slide, please. And here, this whole mass, you can see them right here completely. Next slide. And then fiber optic bronchoscopy was done. There was a growth at the apico-posterior segment of the left upper lobe, 4 centimeters from carino, obliterating the subsegmental bronchus, and the biopsy was small cell lung carcinoma. Next slide, please. So PET-CT was done, and then the left lung mass with the FDG with mediastinal lymph nodes, and the MRI brain also showed multiple well-defined altered signal intensity lesions in bilateral frontoparietal regions as well as the both the cerebellum. So next slide, please. So these are the PET scan pictures showing clearly the mass, the extent to the mass completely. Next slide. Yeah, so the mass is quite extensive. Next slide. So these are the frontoparietal areas, both the masses as well as the cerebellum. Next slide. You can see both the things a little asymmetrical. Next slide. So final diagnosis we have here is a small cell carcinoma of the left lung with brain metastasis. So it's an VALCG extensive stage disease. Next slide. So according to the NCCN guidelines, I think we need to do the MRI brain definitely as the initial part of the evaluation. I think that is done so that we classify the patient into a limited or the extensive stage. So all the panelists, are they okay with the type of investigation that this patient had, or any change in their thinking or thoughts?
I think it's a pretty clean. The investigation have been done very well, and then I think we reached a stage where the treatment decisions should be made now.
So this patient was asymptomatic. The point we're trying to drive here is the patient was asymptomatic from the CNS point of view. He had only respiratory symptoms, and yet we did the brain MRI. So it should be done in every patient of small cell lung cancer.
I do think so. We should do brain MRI in all patients of small cell lung cancer because it's a disease we know which will spread. And to begin with, we have T4 kind of primary with mediastinal nodes. You didn't mention whether it's N3, but it looks like small cell lung cancer. We should do a brain MRI is the bottom.
Right. Even if it is looking, even if it is looking like a small lesion, this is an extensive lesion. Even if it's looking a small lesion, I think we should recommend that. Point well taken. Thank you. So next slide, please. So the next thing is the treatment for this patient. So how do we treat this patient? So before we go on to the thing, so he had asymptomatic brain mets, both-sided cerebral hemispheres as well as the cerebral hemispheres. Both of them were there, and he was asymptomatic. He was symptomatic for the cough. So Dr. Devender, I mean, how do you proceed for the treatment for this patient?
Good evening, everyone. This patient, as we know, is fully worked up with extensive stage lung cancer, small cell lung cancer. Because he's asymptomatic for the brain metastasis, no intervention is recommended at this stage for brain metastasis. We have to start systemic therapy, which will take care of the brain lesions, and then brain lesions have to be followed up later on for planning further radiotherapy if response is there to the systemic therapy. So right now, I'll want to start the systemic therapy initially, and will not do anything for the brain metastasis right now.
Right. So does Bhuvan and Nishant and Akhil, do they concur with this, or any differences of opinion?
So my worry is the infratemporal brain lesion. It's a huge lesion in the right cerebellum. So I do agree with Dr. Devender that starting a systemic therapy makes sense. But then I would like to closely follow up the brain lesion and probably get an MR done after 2 cycles only and not wait for another cycle. I would not like to give the patient a long time, because if the patient starts to have a mass effect, it will probably be a catastrophe for him. So a very close relation, very close, rather than putting it on the back burner. I would like to keep it rather every cycle. I would not mind getting MRI done before every.
Okay, so right, I think there's some connection problem there.
Sir, I've lost his connection.
If you're losing the control on it, I would get.
Right. So there's one question, comment from Dr. Sahu here, saying that in practice, 8 out of 10, he will receive RT to the brain. How many people will vote for it? I think amongst the panel, nobody said that they will be going for RT, right? Is there anyone? Akhil, what do you think?
Sir, in real world practice, I agree that this patient will receive RT because doing MRI after every cycle or after every alternate cycle is actually difficult in real world scenario. And this patient in our practice is going to receive whole brain radiotherapy. And I take the point of Dr. Bhuvan very seriously that it is an infratentorial lesion. The right cerebellar lesion is a big lesion, and we are worried that this might cause severe symptoms in next few days. So
Right.
why to wait for a deterioration of the neurological PS?
Right. So in case you're starting with the whole brain RT, can you also start with the chemotherapy, or you'll hold on to the chemotherapy?
It's fine enough to start with both treatments simultaneously.
Right. So any comment from Devinder or GS?
Only thing is that if you like whole brain RT, it usually causes neurocognitive dysfunction. So
No,
that is one of
neurocognitive immediately, or is it you expect it as a delayed complication?
yeah. Early complication also sometimes the general condition performance status deteriorates.
Right.
So I would
So going by the data which is available to us, this patient will not survive more than 15 months, 12 to 13 months with these brain. And I don't think we can avoid a brain radiation. We will have to give brain radiation sometime or the other in the life.
Right. I think fine.
Completely
so,
agree with
Bhuvan,
your
you
point,
also
Dr.
agree
Bhuvan.
that you would like to start, as Akhil has said, you would like to start both the thing that is chemotherapy as well as whole brain RT, or only whole brain RT and then sequence it with the chemotherapy?
So I personally think I would like to give it a shot of chemotherapy to begin with, and I can very well keep the patient in a closed loop. Even a single cycle of what I believe is if there are these are chemo responsive tumors. 60%, 64% patient do respond to tumors. I would like to get a pre-RT there, but then if the patient is sick, if he doesn't tolerate chemotherapy, it might just create a mess for a 63-year-old male.
Right.
So I would like to sandwich it, like probably give 2 cycles of
and then probably give it the second cycle so that I'm a little more sure about his tolerance.
Yeah, fine. So Nishant is giving a comment there. I think his microphone is having some problem. So he would like to start with the whole brain RT first, and thereafter, Nishant, would you like to give both together? Like start with the chemo, immediately start with the whole brain RT. How toxic is a combination of both the things?
Nishant sir, you have to unmute yourself. Nishant sir, you have to unmute yourself, sir.
Nishant, kindly unmute yourself. That's why you're not audible. Your mic, please unmute your mic.
Sir,
Right.
can you pass on the question to next?
Fine. So Dr. Sahu is asking, what is stopping us from radiation? What is stopping us from radiation? Bhuvan, I mean, you wanted to start the chemo. What is stopping you from the radiation?
Actually, nothing, sir. Probably I think just about the tolerance. I don't think we have a data.
My point was, if I can come in very clearly, it is just a 10 fractions. And the delay of 2 weeks for such a bad patient and 1 or 2 seizure episode can really kill the patient. And they never come out to receive chemotherapy even. So my question is, in a asymptomatic non-small cell, 1 or 2 lesions is a very different scenario. What you showed, the number of lesions, I would myself push for a radiotherapy. And sometimes you are at loss of words. If you have a seizure, you have not given radiotherapy, you lose even 1 patient out of 100. You don't know what to tell to the relatives. You cannot explain that in asymptomatics and symptomatic debate looks good in this symposiums. But in the real world, you have to talk to the patient. I have real issues with that. I'm sorry.
Okay, just a point. So sorry, sir. Do you think, Dr. Sahu, what Dr. Akhil suggested, a concurrent CTRT in the form of that you start with the E2 carbon?
And then nothing stops us from giving a carboplatin, a single shot with the radiotherapy. After 2 weeks, you can just from the second cycle start off with your etoposide and carboplatin.
Yeah, I think that would be a very practical suggestion. I agree with you that we'll have to start both together. And so that we take care of the systemic as well as the local treatment to the brain. Right?
If we have to give chemotherapy along with, then definitely it has to be like intensity of chemotherapy has to be less as compared to the like full chemotherapy.
So I'll ask you all one thing: when we do the small cell in the limited stage, we start with the chemo RT together, both cisplatin and etoposide, the standard along with the RT to the thing. When we can do that, why not the brain RT?
So as per the recommendation, I generally start with the second cycle. I probably follow the Devita there. Devita said you can start with the second cycle. So I probably take it Devita that I started with the second cycle because I generally look at the first. So, second and third cycle, you give it along with it so that you have seen the tolerance of the patient. Yeah. Coming another, I think you can add a Tizo plus Carbo along with the RT. I will be more comfortable.
I'll come to that. Just a minute. Can I have the next slide, please? So, yeah, I think so. This is the NCCN guidelines, which says about the combination of the systemic treatment. Here we are with localized symptomatic brain metastasis, good PS combination, including the supportive care, and then where is it? Brain metastasis, extensive stage with brain metastasis. Asymptomatic may administer. I think it's both ways are possible. If the patient is symptomatic, I don't think there's any doubt about that. Next slide, please. So patient received the chemotherapy first, and that was not mentioned here, but I think he must have got the whole brain RT also simultaneously. So 3 weekly. Anyone, I think, who made this? Akhil, you were. Yes, you can clarify this as to when the patient had got this.
Yeah, sir. Actually, this patient was started on whole brain or RT upfront, and after 10 days of the the patient was started on cisplatin etoposide around 5 days later of the completion of whole brain radiotherapy.
So he had to wait for roughly about 3 weeks after the diagnosis and 1 week after the completion of brain RT for the first cycle, right?
This is what happened in this patient.
Right. Okay, fine. So he received like that. Well, next slide, please. So I think so. Here the audience opinion was asked for as to what are the criteria for right therapy selection in the order of priority here. So performance status, GFR, age, older than 65 years, and we should have a geriatric assessment, serum albumin, symptomatology, brain mets. I think all of them have got. I will not spend much time over here. Let's just go to the audience poll. Next slide, please. So majority of them have said 71%, that is performance status, and then next is the kidney function, and then rest all are scattered. Just a minute. Can I have the previous slide, please? So does the panel agree with all this? Because all the others are like, say serum albumin, somebody has said is higher than all others. May I ask the panelists starting from GS?
So I feel that when we are seeing a patient in front of us, and I would agree with Dr. Sahu, that if you've got such extensive CNS mets, I wouldn't care too much about the albumin at this moment. I would rather, separate my small cell lung cancer patients of whether they have CNS mets, which are extensive, and those which don't have any CNS mets. And CNS mets and the performance status and the symptoms of the patient would be priority 1 to decide on what to give first.
Right. Okay. So they're right. Okay. When kidney function, the performance status, and
understanding that they would be normal.
Right. Devendra, any deviation, only deviation, not without repetition.
So performance status is the foremost criteria to start the chemotherapy and to
do you agree with most of the opinions which have been given by the audience?
Yes, definitely.
Yes. Right. Akhil and Priya, which is just there now. Any? Right. Okay. So I think we'll go on to the next slide, please. There's not. So next slide. So treatment strategy. I think the audience opinion was asked for chemotherapy alone, and then whole brain RT followed by chemotherapy, and all the other options are listed over here. How many patients would go for the chemotherapy and IO? Only 14%. So I think that's an interesting. This is worth discussing. What about Akhil? Can you comment on this? What would be your choice? You have a choice to use anything in this patient. Immunotherapy, chemotherapy, anything. So what would be your choice?
Sir, actually, in such patient, we would like to start whole brain radiotherapy as we discussed previously. Yeah. And as Sahu sir mentioned, giving AOC5 carboplatin.
We'll keep the whole brain RT aside. Okay, now we're talking of chemotherapy and immunotherapy. How many of us? We will just leave the whole brain RT. That's been will not repeat that. So the choice is between chemo and immunotherapy. And the patient's affordability is not the issue.
If affordability is not an issue, definitely we'd like to add chemo plus IO.
Yeah, Bhuvan, option?
Chemo IO, sir, standard.
Chemo IO, both. Yeah, Devendra?
The chemo IO is proven, but in the atezolizumab trial, the only subgroup which did not gain from immunotherapy was those patients with brain metastasis. So
Right.
there was no more adverse effect, but that patients with subgroup with the brain metastasis didn't gain much from the brain metastasis.
Exactly.
So, but this data is not available for with durvalumab. So I cannot say anything about that. But for Atizo, definitely that group didn't gain.
So, yes, well, how will you manage such a patient?
So
You have all the options.
I would prefer chemo and immunotherapy because I would understand that these tumors are more immunogenic and they have a high mutational burden. So chemo and immuno has been shown to be better than chemo alone. And the time there's responses once they occur in those people who are responders, they would be durable.
So the question we are asking is, in presence of brain metastasis, is immunotherapy and chemotherapy as effective as without brain metastasis? We'll just look at that paper. So I think let's see the audience. Next slide, please. So here, a lot of people, this is the audience opinion. Treatment strategy, most of them have gone for, what is the question? Can I go previous? Drug of choice. Okay, so drug of choice is fine, quite this thing, right? Okay, next slide, please. I think here also no question. No, next slide. Next slide. I think we'll skip this. So we have just discussed Atizo. What is the combination? So if you're using the immunotherapy, what would be the preferred immunotherapy agent? So starting from GS this time.
So from the Caspian trial, we know that Durva with chemotherapy has a slightly longer survival. So with the current evidence, based on the Caspian, I would prefer durvalumab with cisplatin etoposide rather than Atizo and chemo.
Right. So any difference, Devinder? Devinder, any difference?
Yes, definitely we know that with Atizo, the hazard ratio was 1 point something when with patients with brain metastasis. So my first preference will be durvalumab if it is available. Durvalumab plus chemotherapy.
Available. Everything is available.
Yeah.
So I probably would choose Atizo. I understand the data is not there, but I don't think there's a different mechanism of action between Durva and Atizo.
Right. Akhil, your choice?
Sir, both are fine for me, but the only advantage with Durva being that we can both give cis or carbo based on this trial because Caspian included both cis and carbo.
Right. So, Dr. Priya, anything you want to say? You're a surgeon.
No, I'm the silent spectator here, sir. But
I was wondering
for a limited stage, I would have for extensive stage as a.
Right. Okay. So I think
Sorry?
any of them can be. Yeah. Next slide, please. So I think I will not go into this. This has been already discussed. Next slide. Next slide. Next slide. Next slide, please. We'll just come to no. I think these are all mostly answered questions. Next slide. So I think all this has also been asked for. Next slide. Next slide, please. Yes. Now this is the studies where we all know that the brain metastases do very badly. So I think the overall survival is about less than 1 year, less than 9 months actually. Next slide. And when in the Caspian study, the difference between the with brain metastasis, the overall survival was 12 versus 8.8 months. Mind you, the HR thing is, though it is 0.69, it crosses the midline. It's 1.31. So how much significance would you give it to this? So what it is saying is that though it is there is a difference in the median overall survival with brain metastasis. Is that satisfying you with HR ratio, the confidence interval? Bhuvan and Akhil?
Sir, I would like to tell that since it is a subgroup analysis and we can see the number at risk is only 28 and 27. So this is a small number of patients to decide whether this is actually benefiting the patients. So that is why the trial is not powered to answer this. However, based on the overall data, I will be still convinced to use the drug even in patients with brain metastasis.
Right. Okay, fine. So that's I think everyone agrees with this. So given a choice, you would like to use all the entire combination. Like next slide, please. So here the brain metastasis also, if they are present, it crosses the midline. That's what we've seen. And whereas if there's no brain metastasis, the advantage is much better. So this also, does it still warrant asking for the immunotherapy in these brain metastases? You still go for the brain mets here, the immunotherapy?
Actually, this is the like for this reason only I was saying that like preferred immuno-oncology agent for this patient will be durvalumab rather than atezolizumab, because like although the number of patients are less with brain metastasis, but still some data is available. So
right. Okay. Next slide, please. Here, this is the first and the only approved in immunotherapy has got the atezo combination. Next slide.
So how many did received whole brain RT before that trial? As in, so we are deviating from it in the IM power 133.
Can we go back to the slide, please? Can we go back onto the slide, the forest plot curve?
So do we have a data on that?
I don't have offhand. Anyone maybe? Akhil, can we just go back one more slide? Yeah, here. So brain metastasis, they have not mentioned about the treatment, but brain mets, yes, number of patients was 35 versus no brain mets was a lot. So I think the number of patients were very, very less. Yeah, I don't think we'll have to look at the complete data, how many received the brain RT.
During the study, none of them received both. They had to have a stable brain mets. So
right.
This was the patients who had brain mets at the inclusions.
Right.
If you look up the PCI, then 4 to 5% received PCI.
Okay.
No, so I think that's what changes the entire treatment paradigm. So once we ask a question whether we are going to give IO in such a patient, but then because our patient has received whole brain RT to begin with. Yeah. So I think
in a trial setting they would not do this as we do in this.
Exactly. So we have already taken care of a brain metastasis at our end, is what I'm trying to tell you.
Okay, next slide, please. So I think this we have answered more than next slide, please. Yeah, next slide. How much time do we have, Jatan? So here we have both the agents, durvalumab as well as the atezolizumab with the combination of the ETO and platinum combination. Both are approved and both have category 1 recommendation. Though the survival benefit is very modest, but I think these are now well proven. Next slide, please. I don't think there's any debate about that. We said any of them can be used. Both agents can be used. Next slide. Role of PCI in extended stage small cell carcinoma. In a patient who doesn't have brain metastasis and then local EBRT. I think these are the important questions. So we'll not talk about the patient that we just presented. If we just take that same patient with extensive stage, maybe bone metastasis, and after 6 cycles of chemotherapy, 4-6 cycles of chemotherapy, the patient has responded extremely well. Near total CR if the patient has. So what is the role of PCI and role of the local EBRT in the rest?
Am I audible now, sir?
Yes,
sir, am I audible?
Yeah, Nishant, audible. I think you're not.
Sorry, yes, sir. There was some technical. Yes, sir. Sir, basically there are 2 studies which are for this extensive stage. Initially, URTC study which has showed definitely PCI has an improvement both in OS as well as PFS. However, in those cases, after chemotherapy, no baseline MRI imaging was done prior to giving PCI. So that was the only detriment in that URTC trial. However, a Japanese study subsequently carried out the same PCI in extensive stage, where they did a baseline MRI imaging after 2 cycles of chemotherapy, and that study excluded the patients with upfront brain mets. So Japanese study says with good PS, surveillance can also be, vis-a-vis surveillance can also be offered to such patients rather than giving PCI. But in Indian setting, where surveillance is there is a question of surveillance, rigorous surveillance, I would like to go ahead with PCI. But data are there both PCI as well as surveillance in such a scenario.
Right. So will everyone resort to both EBRT, local EBRT and PCI? Akhil, a quick answer.
Yes, sir. If extrathoracic disease is well controlled, definitely adding local EBRT might lead to some benefit in the progression-free survival. And PCI answer has already been answered. If surveillance is not feasible, we would like to give PCI. If surveillance is feasible, surveillance is an option.
Right. Okay. So I think we're running short of time. Next slide, please.
All questions, sir.
Yeah.
So I don't think any of us disagree that we would give PCI and thoracic RT. So my question is, when would you do it? Would you do it would you do it at upfront, or would you, as in just after finishing of the 6 cycles, or would you want to wait? Would you want to wait for 2-3 months to see if the disease is coming back? I think the timing is what I would want to.
The timings are after every 2 cycles of chemotherapy in extensive stage, we need to go ahead and get an MRI brain done, because in extensive stage,
we are talking about a PCI. You see, we are talking about
yes,
a PCI.
sir, same PCI. Yes, sir. Before going for, suppose if you are not giving PCI and we are waiting for 6 cycles of chemo, so I think the guideline says that even after 2 cycles of chemo, we need to get an MRI brain, I guess, to see the brain status.
But we don't do so in real world scenario.
I don't think this indication is
Actually, the real first thing, we don't do. Maximum we would do a PET scan response, and we don't do MRI brain all the time. Maybe at the end of the treatment, we generally do if the patient is asymptomatic.
Okay.
After finishing treatment, we can.
So
after finishing treatment, we can do a imaging and then can take up the patient for PCI.
That's what my question was. Would you want to wait after finishing the treatment for some time?
No. Definitely, we would not like to wait, because that is the time which, if it comes in the brain, if we are waiting, that the benefit of PCI goes. That is the benefit, that we are delaying progression in the brain. That is why we would like to give early at the completion of the 6 cycles.
Right. So one last question before we all part, and then that is there any role of maintenance therapy with either immunotherapy or chemotherapy in the small cell, especially the post-immunotherapy era? Quick and last question.
We can give only ICI.
IO maintenance has to be done.
IO maintenance, even though you have not used IO in the induction. Supposing the patient has not been given the induction IO, then
if you're going to do IO in the first settings, all second line IOs indications have been taken out. Nivolumab was pulled off from US market in December, probably because they could not find an evidence of a single agent IO in second line. So if I have to do it, I'll do it in the first line IO.
Pembrolizumab maintenance was tried as maintenance therapy after induction therapy, and it was a negative trial. So there's no point using
Thank you. I mean, I get a very comment from Priya saying that excellent discussion, thoroughly enjoyed it. I hope you did, Priya, without any question on this surgery. So thank you very much for participating, everyone, and thank you.
I did. I really enjoyed it.
Thank you. Bye-bye. Right.
Thank you so much, Dr. Rangarao sir, and all the eminent panelists for the fruitful discussion. Now, moving ahead, I'd like to invite Dr. Shyam Agrawal, Senior Consultant Medical Oncologist at Sir Gangaram Hospital, New Delhi. Sir will be enlightening us on turning the tides with targeted therapy for resectable early stage EGFR mutation non-small cell lung cancer. Latest data and practical. Over to you, sir.
So, I think we are towards the end of the session, and I'm supposed to discuss the role of EGFR inhibitors in early stage resected, mutated non-small cell lung cancer. So can I have the next slide? I'll finish in about 15-20 minutes because we are running late. So this is the data as it stands for non-small cell lung cancer who've been operated, and the role of adjuvant chemotherapy. And as you can see, survival due to chemotherapy in stage 1, where it is minuscule and therefore not approved at this point in time. And in stage 2 and stage 3, again, you have really modest, gains in the resected stage 2 and stage 3, which leaves a lot of room for improvement. So let me just say this here. I wanted to put in a slide that if you look at the overall survival hazard ratios in the adjuvant chemotherapy studies, so it's around 0.7, 0.8. So, it's hardly there, as you can see the survival due to chemotherapy, which is, to the tune of 10, 15%. So, that is where we stand, and we use chemotherapy in all our stage 3 and tumors of stage 2, which are more than 4 centimeter. So with a benefit or hazard ratio of 0.7, 0.8, we are using chemotherapy. So let's move ahead with this background. Next, please. So I think, as I said, there is a huge room for improvement, and we all know the staging system. And so EGFR TKIs have become the standard of care for mutated NSCLC with very high response rates to the tune of 80%. Next, please. So what is the role of adjuvant therapy? We all know it can go to cure, it could control and delay, and it may be unnecessary, as you saw in stage 1. Next, please. So I think that is the EGFR timeline where we've had, IPAS study to begin with, and then we are in the era of third generation TKIs, where, you had the approval virtually in 2017-18. And then, of course, what I'm going to do is to sort of discuss the role of osimertinib in the ADAURA study, along with some data from the other EGFR TKIs. Next. So coming to the ADAURA study, which is a double-blind study here. So it is important to read the inclusion criteria. Resected stage 1B, 2, 3A, with or without adjuvant chemo. So which means some of the patients did get adjuvant chemo. And brain imaging was done, if not completed, pre-operatively before enrollment. And all the patients, of course, were mutated. This is the 10-week without adjuvant chemo and 26-week with adjuvant chemo. This is the interval between surgery and randomization. So this is osimertinib 80 milligram once a day for a period of 3 years. So that's a long time, a long period, which we also have to remember as a practical aspect compared to placebo. And they were looking at, as I said, the hazard ratio for stage 2 and stage 3A for an assumed DFS hazard ratio of 0.70. So that was the primary endpoint for DFS, stage 2, 3A hazard ratio 0.70. And the other secondary endpoints for DFS in the overall population were for 2, 3, 4, 5 years, and overall survival for safety and health related quality of life. So basically DFS was the important endpoint. Next, please. So this is the these are the baseline characteristics which are fairly similar in both the arms, and you see most of these were adenocarcinoma, and stage 2 and 3A were 35 and 34%, and adjuvant chemotherapy was given to nearly 55% in both the arms. So a lot of patients, more than half, were exposed to adjuvant chemo in addition to osimertinib or placebo. Next, please. So this is the primary endpoint as we discussed, and they were looking at hazard ratio of 0.7, and they got a hazard ratio of 0.17 with a maturity of 33%, osimertinib maturity of 11%, placebo 55%. So this is the DFS not reached in the osimertinib arm in patients with stage 2 and stage 3A. So it's extremely, extremely encouraging here. Next, please. And this is combining all, DFS overall population. Here again, the hazard ratio is 0.21 with these maturity, data. So again, even if you include 1B, where the benefit may be a little less, so the hazard ratio is 0.21. So again, outstanding data. Next, please. Next slide, please. So this is the forest plot. As you can see, for stage 1B, the benefit is there, 212 cases, and we not crossing the midline here. For stage 2 and 3A, of course, the benefit is there. For both the mutations, exon deletion or L858R, you see the benefit is there. And whether these patients got adjuvant chemo or they did not get adjuvant chemo, again, you see the benefit from osimertinib was there. So this is, all the subsets, as you can see, are benefiting in favor of osimertinib. Next, please. So same slide, I think go to the next slide. So now you look at the 2-year disease-free survival stage-wise, and you see the hazard ratio, 0.5 in stage 1B, but stage 2 and stage 3 hazard ratio is 0.17 and 0.12. 88% versus 32% at 2-year DFS, 91 versus 56. So huge differences at 2 years. Next, please. And in the DFS. Next slide, please. So again, and this is to show you in this format. Again, you see the curves separating virtually at 1 to 2 months in favor of osimertinib in stage 2 and stage 3. Stage 1B, again, you look at the hazard ratio is 0.5, again favoring osimertinib. Next, please. So I think this is per investigator, not much different. Hazard ratios are less than 0.25 in both the cases. Next. So now coming to the overall survival, where the data is still immature, 5% maturity, as you can see, the hazard ratio is 0.4 already, although the curves are fairly overlapping, but then that is the data which stands. But I think patients are still being followed up at this point in time because we're still waiting for the overall survival data. Next, please. So now coming to the safety, here you see any adverse events. The patient has to take the drug for 3 years. So 20% of these patients had greater than 3 grade adverse events, and 11% patients had to discontinue the drug. So any AE lead to dose reduction is about 7%. So, so this is something which you need to look at. Although osimertinib is fairly well tolerated, but as perhaps you take it for a long time, well, some patients, around 7% patients or 10% patients, will be withdrawn from the drug. Next, please. So now coming to the all causality adverse events, more than 10%. You see in the osimertinib, diarrhea stands out here, 46%. And the other ones, I think the skin toxicity and some stomatitis. So it's fairly well tolerated, but there are issues which I just mentioned. And there is QTc prolongation in 22 patients in the osimertinib arm. So I think that's another important effect which we need to follow up and do the ECGs regularly. Next, please. So I think to conclude on this, overall 79% reduction in the risk of disease recurrence or death with osimertinib. So this is, and I showed you the DFS at 2 years, 89% and 53% if we take the overall population. So it's a highly effective practice-changing treatment, which did see the approval from FDA in December 2020 after complete resection for non-small cell lung cancer. Next, please. So I'll just come to, this was published, recently. Next, please, in NEJM. So a few slides more on the CNS, which were published in ESMO. Next, please. Next slide. So I think you also need to look at the sites of disease recurrence, including CNS, because osimertinib, as we all understand, crosses the blood-brain barrier. Next slide. So I'll not go into the details of this. I've already mentioned nearly 37% of the patients in the RADIANT study had, CNS involvement on follow-up. Next, please. So types of disease recurrence on osimertinib, 11% are, recurrences. And out of these, you see 38% are distant recurrence, including brain. So when you do the placebo, 61% patients would have a distant recurrence. So what is the impact there? Next, please. So I think if you look at the CNS patterns here on osimertinib, only 1% as compared to 10% patients had recurrence in the brain. So again, showing that osimertinib is able to prevent the CNS recurrence. And disease recurrence in any location, 11% versus 46%, lung 6 versus 18%, nodes 3 versus 14%. So overall, I mean, we understand that benefit is there in terms of not only the loco-regional reduction, but also the distant reduction there. Next, please, and including the brain. CNS disease-free, I think already said, 1% versus 10%. And so again, osimertinib, proving the point there. Next, please. I think this is again to show the disease-free survival on the CNS. You see the hazard ratio 0.18 in spite of, less maturity. I think some follow-ups are required. Next, please. So this is conditional probability of CNS and non-CNS recurrence, again favoring osimertinib. Next, please. So again, to share with you, this is a summary kind of a slide where, the other EGFR TKIs in the adjuvant setting have been used in the select where erlotinib was used. So most of these are with erlotinib, and you see some benefit there, but the hazard ratios were not that good, than what you saw with osimertinib. And therefore, for example, some of these studies even had no DFS in BR.9. So none of these drugs have seen the approval. So osimertinib for the first time has shown the excellent data, not only in the local recurrence was also in the CNS, and therefore given the approval. Next, please. So I think this is the final slide demonstrating that in the CNS also the hazard ratio is 0.18. So reduced risk of local and distant recurrence, improved CNS DFS, reinforced adjuvant osimertinib in all the stages of resectable EGFR mutant NSCLC. And therefore, I think one needs to consider this once perhaps we have the approval from the Indian authorities in this setting. So with this, I think we are seeing a new drug here showing benefit. Thank you very much for your attention.
Thank you so much, Dr. Shyam Agrawal, sir, for the wonderful talk and enlightening us. Now, moving ahead, I'd like to invite our lead discussant, Dr. Rahul Sood, Head of the Department and Associate Professor of Medical Oncology at Command Hospital Air Force, Bangalore. Over to you, sir. And we have our experts, Colonel G.S. Chaudhary, Dr. P. Suresh, Lieutenant Colonel Dr. Amol Patel, and Dr. T.P. Sahu. Over to you, Dr. G.S. Chaudhary.
Thank you so much to the organizers, and very humbled by the organizers, and definitely an opportunity for me to meet my teachers and people who've taught us at various instances. So I'll request the organizer if they can project my slide sets. These are all the questions that we've received periodically during the course of this presentation in the chat box, as well as a few questions that probably I would like to ask our expert panelist. Request the organizer if you could just project the slides, please.
Vidyut? Vidyut?
Okay. Fine. So I think I'll have to go extempore, and there's nothing better than that. And since we are the last in the line, and before I receive a call similar to what was received by one of our senior colleagues in Delhi from my wife, when I'm live, I think we'll go extempore. So my first question, I think, is for Colonel G.S. Chaudhary, sir, who is one of our senior most oncologists, and I happen to have learned from him during my general medicine time. Very fortunate to have him here. So my first question is, and it's all I'll keep learning from you so often. How much of stage 1, 2, and 3 do we see nowadays, sir? I keep seeing only stage 4, sir. So your experience, sir.
I would totally agree with you. In fact, to begin with, CA lung as such, I don't think we see that much of stage small cell lung cancer as 15% also in our practice. At 15 and 85% is how we divide it. Now, talking of stage 1B, I would have seen maybe an odd patient in a year who is incidentally detected while doing imaging for some other cause. So in our practice, most of our patients would come in 3B or 4, as you very rightly pointed out, Rahul.
Right, sir. Right, sir. So my next question is for Dr. Colonel Suresh, and I really admire him for his correct and straightforward answers, and without what do we do when we receive a stage 3A lung cancer? And so this is probably one of the gray areas we keep facing, and probably a question that you'd also put for us during our exam, and especially our preparatory exam, and I did very poorly in that. So, sir, from your end, sir, stage 3A lung cancer, sir, who does it belong to, sir?
So I think this is one of the gray areas of management of non-small cell lung cancer, where all the specialists are involved. Most important thing to realize is that just of oncology, that is medicine, surgery, as well as radiation, is involved in the management of stage 3A. Sorry, stage 3 lung cancer specifically. And now 3, the problem with 3 is that it has got various subdivisions into it. It can be because of invasions. local invasions, or it can be because of increased nodal staging. So depending on the various situations, the management differs. So I would say we cannot encompass an answer to this question in about 1 or 2 lines. It's a major discussion per se. But broadly, we can say that up to stage 3A, we would consider surgery also as one of the important options of management. Stage 3B, generally, most centers would consider chemo radiation onwards, and a few centers maybe may consider neoadjuvant settings and even surgery. So that is how I would put it. Depending on the reason for being stage 3, the type of management may change.
Thank you so much, sir. So my next question is to Colonel Amol Patel, sir. And I know sir loves breast cancer, but I think lung cancer is also one of his favorites, I know. And with his experience at AIMS, he brought a lot of flavor to Army Hospital RNR. And really, it was a pleasure learning from you, sir. Sir, just a question to you, sir. So do you insist on clinical staging or invasive pathological staging, sir, for these kind of what is your take on that, sir?
So in many of our hospitals, as already brought out, always it's a stage 4 in the domain of the medical oncology, and whenever it is the evaluation for stage 3 or even early, we find so much of difficulty. Certainly, yes, invasive staging is a standard of practice, is basically well established, like mediastinal staging wherever it is required, and whatever the PET CT guides you to which patient to select for the mediastinal staging. So it should be the integral part of management. I don't deny with that there are no much difference in when it comes, because majority of patients, they really come in an advanced stage, and even with the half-heartedly done mediastinoscopy doesn't feel much. But whenever possible, if it is indicated, it should be done. The invasive staging and the proper management. So it's not with our own experience, but certainly at All India, whenever there is a nodal station at only subcarinal, it is to be addressed carefully. And if it is bulky node at more than 2.5 centimeters, certainly many times we used to think about neoadjuvant chemotherapy, and if response is good, then the surgery is offered to the patient. But this is very rare situation. We don't come across regularly in such situation. I think now with the figuring out the all the teachers, and Dr. Sau would answer your questions much better, because he's the one of the stalwart in the medical oncology field.
So that is why I've kept the most difficult questions for Dr. Sahu only, and so that I don't get beaten up by my old teachers. So I am that way very sly. So my next question goes to Dr. Sahu, and sir, one line answer, sir. How would you manage stage 1B, stage 2, and stage 3A, sir?
The army has to be fair. Huh? The armed forces cannot be unfair. That's the point. Okay. So we are talking of it's very clear. I agree to most of the thing what has been told. In my practice, I would be seeing some 1 or 2 cases which I send it to a center for surgical opinion. But what I feel is mediastinoscopy with the advent of PET scans, and if there is a definite high volume disease in the mediastinum, which you're very sure of N2, N3, people do not venture for that. Otherwise, I think if there is N1 and you want to really operate before that, all of us should advise a mediastinoscopy. That's where I put it up. Coming to stage 1, it has to be it's a surgical field, and I think surgeons are the boss, and they have to only decide about it. If it is not operable, if it is operable but conditions are not fit enough, GC is very poor, then a radiotherapy really comes in as the alternative. And if we are talking of a surgical and stage 2, all of us know again the same way goes through its surgeon's field, and then the adjuvant therapy is decided after that. But if you're looking beyond that, and if you're looking at the adjuvant therapy, if you're talking about adjuvant, yes, anything.
Sir, would you like to put Anita somewhere, sir? Would you like to put Anita somewhere, sir?
Yeah. I would, without that thing, yes. Anything beyond a size of 4 centimeters or a node positive is something which I would definitely give adjuvant therapy. 4 cycles is the minimum what I would advise. The choice of treatment can change. You have vinorelbine, you have your Pacli, you have your Pemetrexed also trials that is for 6 cycles in the adenocarcinoma. But if we're talking of adjuvant EGFR beyond that, if it's a mutation positive, that I think discussion we will have it later on.
Thank you so much, sir. So Chaudhary sir, I'd like to ask you a question, and many times this is something that we come across. What would you do in case a patient refuses surgery or is too comorbid and prohibits surgery, probably because of his comorbidity, in a case of early lung cancer? So what would you do, sir?
So in our practice, many times we encounter people who have, about 80 years old and they have comorbid illnesses, and they may not have adequate renal or hepatic function. And then probably radiotherapy would be the choice of treatment if
Right,
he's not EGFR mutated.
Right, sir. Right, sir. Suresh, sir, one question for you, sir. Yes, sir.
Would the treatment change? I would like to come in just now. Would the treatment change for a, let's say, early stage 1, 2A, not fit for surgery, and you send it for SBRT or a radiation? If EGS are mutation positive, would you not just give radiotherapy, and would you start off with a neoadjuvant gefitinib or osimertinib? That's what you suggested here?
No, actually, I'm not suggesting that. We probably wouldn't even test him for that.
Oh, you won't test for that. Okay.
Sir, we'll come to that question once again, sir. But I think probably if we are not, because we've not made it a habit of testing EGFR for early early lung cancer so far, so we're still going in the retro fashion, sir. So, Suresh, sir, one question, sir. If a patient has a R1 or R2 resection, sir, and what do we do next for such a patient, sir? Early lung cancers.
So ideally, if it is possible to do a re-resection, it would be ideal for R1.
Yes.
But we know practically most of the situations, the reason for R1 and R2 is because the surgeon could not do a R0 resection due to certain limitations. So the next ideal treatment would be giving radiotherapy plus chemotherapy in R1 and R2 resections. So now the sequence, it could be concurrent chemoradiotherapy would be the most ideal, followed by some adjuvant chemotherapy. But the tolerability will be an issue post major surgery. Depends on what kind of surgery the patient has undergone, lobectomy, pneumonectomy. So the major issue of stage 3, as you were discussing, was that we are exposing the patient to all 3 modalities of treatment at once, and that is going to increase the toxicity. So our aim is to, if possible, to only restrict the patient to 2 modalities, if possible.
It's a very imaginary situation. I didn't come across with R1 or R2 resection. Anybody has any experience with this? I don't think so. Any surgeon around?
I think there's no surgeon there, but
if they select the case, it's generally a very selection is very careful, and I have not come across with such clinical situation. That's what I mean.
So many times it happens probably intraoperatively, they find the vessel involvement, and probably the radiology was not that specific as they thought. And intraoperatively they found, and we've had 1 or 2 cases where this has happened. Okay. So what is your experience with post-op RT in such cases, or especially when the surgical margins are there, or stage 3 N2 disease, sir? What is your take on that? Is there any benefits, sir? Oh. Data doesn't show much, sir. Sahu, sir? You're
asking me? Yeah, for me, it's very clear. If it is a R1, first things first, yes. If there is anything beyond a stage 3, I would be advocating adjuvant RT along with chemo. Otherwise, I would not. But if there is a R1, irrespective of the stage, I'll be advocating a CTRT. Last thing I would like to tell, yes, I agree to one of the panelists that there has been a trial, although these type of surgery did matter. If I'm not wrong, it's ECOG or SWOG trial, I'm not sure of that, that showed that a trimodality is not superior to bimodality. So the lobectomy and the pneumonectomy did come in that analysis, but all said and done, except for a select group of patients, maybe in stage 3, most of the patients would receive a single or a double. Most of them will be double. In stage 3, by virtue of the disease load, it will be most likely a triplet therapy because the disease is like that. The exceptions are superior sulcus tumor, where chemoradiotherapy does come in.
Sir, a common opinion of the House, do we routinely or are we planning routinely to do an EGFR mutation for early stage 1 to stage 3B lung cancer, sir? So I would like a take of each and every one. So starting with Colonel Chaudhary, sir.
I feel when we look at the colon cancer model, even in the colon, EGFR mutations are an early genetic marker, but we only test it in the metastatic setting. Similarly, in lung,
So, sir, I've lost his network. So, can we move on to the next speaker?
Can I come in? I'm Dr. Sahu.
That
Yeah,
we
sir.
test
I think he's not out. Yeah. So for me, yeah. Okay, he's on. He's on. I think the Adura trial and even the Cetong. Hello. Hello.
Time when this becomes available. Yeah, Dr. Saud, you saying something?
Yeah. I think now the talk of this will happen even in the operable lung cancers because we have the Adura, we have the Cetong. There are two trials which are being talked about the most, although Dr. Sham did show 4 more trials. So I think there are two things here. With the data that is, although I have reservations against this data at this point of time, because if you look at the Adura, not everyone who was eligible for receiving chemotherapy did receive. 60% of the patients received chemo, 40 did not. If I'm not wrong, the Adura's data was that, or maybe 40 received, 60 did not. So the point of my subject is that with this data, with a PFS of hazards of 0.2, it is very difficult for us not to offer it to the patients, especially now on approval. So for me, I would be doing it now for all my patients. Am I convinced of the Adura at this point of time? I have questions. I think 2-3 more years, the OS data which I'm looking at, and all of us have been taught very traditionally that for a early disease, OS is something which we have to look at. And there are concerns about something that has happened. So I think the question is, do we need to do EGFR? My answer will be yes. Would I be offering TKIs to the eligible patients? My answer is yes. Am I convinced still? Probably no. I need more data. Why am I doing it then? It's because I'm afraid of the legal hassles. I would love to do it.
So I think I'll put this question to Colonel Suresh, sir, because I love the way sir answers these questions. And my question is twofold. Sir, would you at Army Hospital do it? And if yes, would you do it on the tissue or in the blood?
Yeah, okay. So I would look at it this way. We know from the advanced lung cancer setting that EGFR mutated lung cancer responds poorly to chemotherapy as well as immunotherapy upfront. So what is the ideal agent?
No. Actually, they respond better to chemotherapy. The EGFR positive. I'm sorry, I interrupted you. The immunotherapy is a different ballgame. I think the EGFR mutation actually has shown that they have a better response to chemo. I'm sorry, you please carry on.
I would beg to disagree on this aspect because we have trials showing that upfront comparison between chemotherapy and the of course, whenever an EGFR agent is given, it is given as a maintenance. So it's not an ideal comparison, I would say. But they show that there is improvement in response rate, PFS as well as OS. Osimertinib has shown us that definitely. And to a certain extent, gefitinib and nilotinib has shown. So what the point I was trying to make is that these are the most active agents in this cancer. And now we have various trials showing us evidence that it is effective in terms of PFS, definitely. And as far as OS is concerned, the matter will be subject to debate. And it will. I agree with Dr. Sahu in the aspect as far as the convincing regarding Adora trial is concerned. I also have certain reservations regarding the stage. If you look at the stages, there are a lot of stage 1B patients in the Adora trial. Okay, they did not allow post-operative chemo radiation. The N2 stage patients were quite low compared to the other trials. So there are a lot of other things, but still we accept that the differences are so huge. So they are definitely a significant improvement in the standard of care. So I would definitely like to do the EGFR testing now in my patients and offer them this therapy.
Amol sir, your take on this, sir, and sir, PFS, sir, not translating into OS, sir. Your take, is Adhura trial still an Adhura trial, sir? Adhura as in Hindi, sir. If I may just joke on that, sir, or again.
See, the same thing happened with the other trials with the TDM1 also, and the same discussions about the. But when you talk about the adjuvant, yes, I agree and disagree with both the school of thoughts, because one is, see, the death. If there are death in the osimertinib 9 and 20 in the placebo, there are death benefit, and similar kind of a death difference was there in the TDM1 also, and we accepted that. So when it comes to adjuvant setting, certainly the power is not for the death, but there is, whatever the number needed to treat, you calculate, there will be phenomenal difference between the cost. And I used to, tell you all these things. But certainly when we talk in such conferences, one thing we always say, the cost is not a barrier. I always laugh at it. The cost is always a barrier. It can't be like that. It's very difficult to, how can be a cost is not a barrier. But anyway, this is how the companies are teaching us, and they tell us that this is what the truth is there and this is what the science, but the ground reality is absolutely different. But certainly, yes, if we go by data, adjuvant, if there is a death rate is death will be prevented, certainly I will take it this as a change in practice and standard of care. In fact, at All India, when I was doing my medical oncology, that time only we speculated this, all these new TKIs will come gradually into the adjuvant setting, and one by one things are changing. In fact, now we will see for neoadjuvant also. So neoadjuvant osimertinib might make a difference in stage 3 and stage 2B also. So this is the changing paradigm. Certainly it is going to, my take is, I like the TDM1, osimertinib is a game changer in this situation.
Sahu sir, a question to you, sir. Sir, you'll have to unmute yourself, sir.
The only last thing I want to tell you in this is, I am interested because of the OS is, how do you manage the patients who relapse after 3 years of osimertinib? That will be a thing we need to learn. So that's why the OS data is so very important for me. That's the only thing. Otherwise, the hazard is something I've never seen for a long time.
Sir, we had the Radiant trial where the erlotinib was used, and we had another trial where the geftinib was used, sir. Sir, Sahu sir, your take on it, and Chaudhary sir, your take on this, sir. Could we use them and then probably osimertinib later on, sir?
No, if I have to use the TKI, I'll use the osimertinib upfront. That's for sure. If I don't use, that's a different thing. So if it is a TKI, it's osimertinib with price is not a concern. I agree to Anmol that price is a barrier and that cannot be taken out. The only thing is that there are subtle differences in the trial which we need to look into. Like Sitong was a trial which is much talked about. The PFS is 0.6 for the Hazard's PFS is 0.6, but it's a trial of a gefitinib versus chemotherapy. These patients were randomized into either of the one. So there are subtle differences which we need to take. What I tell that if a patient is there, slight bit elderly or had a very bad post-operative complications who does not want to take chemo, if EGFR mutation is there, we have now data to give the patient systemic treatment upfront. That's something which is my take home.
And Rahul, I think over the period of time, all this trial is those who design it and the patient selection, the supportive care, the things are improving so much. But when you take the trials around 2 decades ago or 10 years ago, there are a lot of differences in patient selection. So we need to really go into the other trials and what is the difference. So I'm not that expert like Colonel Suresh or Dr. Sahu for lung cancer, but certainly to choose these patients, who is going to benefit or what are the selection or inclusion criteria previously and now, we just need to get a feel of it, which kind of a selection was in this trial osimertinib, that is going to help much. Dr. Shyam Agarwal sir can give some insight to this.
In fact, I wanted to ask this last question to Colonel Chaudhary and Dr. Shyam Agarwal and Dr. Suresh. One is for the EFOG, because we have two very senior oncologists from in the form of Chaudhary sir as well as Suresh sir. Sir, for EFOG guidelines and for our data, sir, would we like to include something like this in our protocols? And sir, Shyam Agarwal sir, what about you sir? What would you suggest, sir?
So you see, I think the lacuna in the trial have been sort of pointed out that you need to, for adjuvant studies, have the overall survival as the landmark, which at the moment, of course, is missing. But, you know, I think the point which was raised by one of you was the patients were given chemotherapy. 55% patients were given chemo and 45 were not given chemo. But if you look at the forest plot, patients who did not receive chemo, they also almost equally benefited. So chemo is not the, the factor. The factor is the EGFR mutation, where osimertinib seems to be doing much, much better than the first generation TKI. And that possibly is the reason for the DFS, hazard ratio, which is so very significant, 0.18 or 0.2. Even, for example, in stage 2 and stage 3A. So where I think even for stage 1, although the number of patients are very small there. So, based on all this information and data, FDA has given the approval for using the drug for 3 years, which I know is very difficult in our scenario because the cost is a huge deterrent. But I think as I was looking at the chat box, although the number of patients are going to be small, but 3 years osimertinib is really going to cost a fortune for us at this point in time. But I think the data seems to be very, very promising. Now you look at the CNS data, which I showed you, the number of CNS relapses are gone down. And as Amol was pointing out, there's a difference, significant difference in the death rate as well. So you can't just look away. I mean, you really have to maybe select out your patients, especially for stage 2, stage 3, and go ahead and give them the benefit of the drug which is available. And the DCGI approval is yet to come, which I think is maybe expected in March, April. So if you have that from our country, I think then we have no choice but to offer to our patients the drug for such patients.
I agree with you, Dr. Shyam. Probably we'll have to wait for the OS data. And even in the services as well as in the world outside, we would probably wait for a generic to osimertinib, which we can actually use and talk about these data for 2 to 3 years. At the moment, in our practice, we probably, the pockets are burnt out of the government also, even if you give a patient 1 month of osimertinib.
Suresh sir, last word from you, sir, before we close, sir.
I was afraid that you would come up with this statement regarding usage of this drug in the army. So,
yes.
I had gone into extra details of the nitty-gritties of this trial for this specific reason. So, I would like to have Shyam sir's as well as Sahu sir's opinion on these aspects, in fact. So the points which I noted, other than what Dr. Shyam Agarwal has already pointed out, is that do we see 32% stage 1B patients in our practice? You see, the number of stage 1B patients in ADAURA trial is 32%. Stage 2 is 34%. And stage 3 is 35%. Now compare this with the Sitong trial or the adjuvant trial. It is 33% stage 2, no stage 1 at all, and 65% stage 3 patients. Okay. The N2 patients are 31% in the ADAURA trial and 64% in the Sitong trial. So, so we are looking at a class of patients who are extremely low risk in the ADAURA trial, I feel. Number two, the patients, anybody who required post-op CTRT was excluded from this trial. So the moment a patient requires for some reason, the ADAURA trial does not include patients. Radiation, post-op radiation was not permitted in this trial. That is another point. Third, of course, one more aspect I would like to say, osimertinib has got much less side effects than erlotinib and geftinib. So we know from the previous adjuvant trials that anybody who took the drug for a longer period, more than 12 months or 18 months, had a better DFS benefit and trending towards OS benefit. So osimertinib, I'm sure patients were able to take for a longer time. So that is why we are getting a very good benefit, that goes in favor of the drug. But these aspects of the stage, the nodal stage and the stage of the disease and the type of surgery also, in the ADAURA trial, 97% underwent lobectomy. So they were early stages, whereas in the Sitong trial, only 80% could undergo lobectomy. So are we delaying a relapse or are we actually achieving cure? So this is my question to both of you, sir. Then we can decide whether we can use it in the army.
See, there are two. I'll come in before because Dr. Sham will have the last word. A small two things. See, for the duration, it is in the Sitong also. It's shown that less than 18 months, more than 18 months, there was a difference. So definitely, duration of TKI matters. That's why that's one of the things why the ADAURA of 3 years is better than 2 years of Sitong. Second thing is Sitong is the chemo versus TKI trial. It's versus. This is allowed chemo in around 50 to 60% cases, and then the criticism of the ADAURA is that few patients who are eligible for chemo could not receive chemo actually. But Dr. Sham had that hypothesis generating, but that could not be a take-home message. But yes, the last point of yours, are we delaying the ultimate thing that is the inevitable? That can only be answered by the OS data. No other data can answer that actually. So my point on take is, at this point, the primary endpoint of the trial was PFS for both of them. The eligibility criteria for Sitong was stage 2, stage 3. That's why they did not have stage 1. For ADAURA, they had stage 1B. So we have to take it on that. And it was a worldwide trial. So that's why they could recruit this amount of patients. And that is how the trials are managed. That's how statistics it is done. So my point is, if a government agency wants to do it, I do not belong to agency. I do not know how they approve it. But I would be having 100 rupees. I have to look at that budget of 100 rupees and look how many patients are there who can be eligible, because I will give it to one. I think I just cannot deny the last soldier on the foot and only give it to the higher rank officials. So I have to give a policy which is uniform. So if I have the budget at this point of time, I would be more than happy to approve such a drug. That's my take on that. Dr. Shah.
Coming to the budget part and to the numbers, you see, as is being pointed out, and as I think Dr. Rahul in the first question asked, what is the percentage of patients who are resectable in non-small cell lung cancer? That's hardly, 15 to 20% if you come to practice. So the number of patients who are going to be eligible, and then you are looking at, EGFR mutated patients, which will be another, only 30%. So if you were to look at 100 cases, 80 will be non-small cell. Out of that, 20 will be around, resectable, and then another 30% of the 20. So, maybe you can calculate the numbers and see how many are going to be coming to the army, how many are going to come to the CGHS, how many are going to come to the private sector. So actually the number of patients in each sector is going to be very, very small to my mind if you do the calculations backwards. So that's, of course, number one. But then, of course, I think in order for us to prescribe the drug, we need to ideally have the approval of the DCGI.
Yeah.
We're going to look into the data, and perhaps they are looking at it, and they are going to be thoughtful. And I think people like us are going to be there on the panel to give the approval to the drug for the adjuvant setting. And if we get the approval, well, sure, all these, the categories of people will derive the benefit from the drug because the hazard ratios are so compelling, you just can't look away. You look at your DFS in colon cancer, FOLFOX versus no therapy, the hazard ratios are 0.7, 0.8, and that ultimately, of course, translates into an OS advantage over a period of time, which gives you the impetus. But initially, the drugs were approved on the basis of DFS with a hazard ratio of 0.7. Here you're talking for a hazard ratio of 0.2, 0.18, which is virtually unheard of. So sure, we are looking for the authorities to give the approval before we can, start prescribing the agent to our patients. But the data seems very, very promising and encouraging.
Rahul, Dr. Rangarao also seems to be online. Can you ask for his opinion, please?
Yes, sir. Yes, sir. Dr. Rangarao, sir, please, sir, your take on this, sir, and I love if you could just sum it up and the final words, sir, from your end.
I think when about the service, I think it's very difficult to answer when you apply to the whole thing. But once the DCGI approves, I think irrespective of anything, every soldier must get it. I don't think we should deny them this thing. The only problem with us is that we do have two cheaper molecules, that is the gefitinib and the erlotinib, and one is not very sure that they could also be as beneficial as they can be, in case we can use it for a longer time. I think Suresh's analysis, I really like that, those medicines cannot be given beyond 2 years. And we'll have to, while we accept that osimertinib has got a very distinct advantage, we must look at the alternative options, the cheaper TKIs. I think we'll have to wait for more data, especially the overall survival. Because it didn't seem to be so impressive. The overall survival was nowhere impressive than, as compared to the PFS. We'll wait for some more time. And maybe we'll get a generic osimertinib in India very soon.
Let me just say this. So actually the data was so compelling, the interim data monitoring decided to break this open. And that is how this whole thing came. It was not the AstraZeneca, it was the data monitoring committee which decided to open the data, and they're still following up the overall survival and all the patients at this point in time. But it is the interim FDA approval which has forced us to, force the company to file for the DCGI approval.
Sir, just one thing will happen is after this, you will have a crossover, and then the OS data will not be there, and we'll be speaking after 3 years. The OS data was not was good enough because they crossed over. That I think will be a take-home message after 3 years.
Look at the OS data, TP. It is only 5% mature.
Yeah, I know.
So the maturity is of the data is not there.
So the point is, when they open up, sir, everyone would be receiving osimertinib now.
But sir, Dr. Shyam said, can I ask you one question? No, as a panelist, you should not be asking the question.
No, go ahead.
So wouldn't be a good thing in India, for the DGGA to say that in the analysis, the way Colonel Suresh has put it, compare the osimertinib with the erlotinib or gefitinib in this situation. Select the similar patient population. So tell your trial is that exactly replicate this 40% of the stage 1 and see what happens. Do you think that there is a potential to not to change much of the disease outcome in this setting, and there will be equal outcome?
Amol, I don't know how they will look at it, but I think when the company files for an approval, they will only perhaps look at that drug and that data and take a call whether this drug can be
this is what is happening, sir. This is what is happening in our community and our profession. Is everything is been told to us by the companies that this is how it should be done, and this is been done. So see, there's a lot of issues in this, which kind of if you take the number needed to treat anywhere in the country with such kind of osimertinib to prevent such kind of death, the number needed to treat will be around 15 to 18. The cost is phenomenally beyond our imagination to save one life. What's your take on this?
I fully agree. Cost is a huge barrier at this point in time. But, as we all understand, for most of the drugs, as time passes, the drugs become cheaper. And I'm sure, I think we all know we do have.
I know this is not the forum, but when it comes to such discussions, when such senior people are around, I will just share with one of the experience with the patient recently. He was posted in Kargil area. His mother had CA lung adenocarcinoma, deletion 19 positive, brain mets, WRT, and from Kokilabin received osimertinib. With the latest data at that time, yes, we took the case for higher headquarters, and at the system in New Delhi, we could only give this patient osimertinib for 4 months. After that, we were just moving with the authorities and explaining that this is the best medicine in situation. Once it has been started, we should give it. Somehow, 4 months, 5 months, and after that, what happened is file did not process, IFA observations, there are a number of things, and subsequently, osimertinib was bought by the patient themselves. For 6 months next, patient has bought the patient out of his pocket. Nobody informed them what is the patient access program. Neither he bothered to ask the companies or the open market what is things are happening. And after that, now for last 3 months, he is buying Bangladeshi medicine.
So that is what is happening.
This is the ground reality.
I know. I mean, most of our patients, they start or want to start with the original molecule, and sooner or later, because of the cost issues, they switch to the Bangladeshi. So
we send money. We send money to USA. Our trade deficit is increasing day by day, and now we are sending money to Bangladesh also.
Come on, let's close this. Yes. I think we are going out of the scientific.
I think this is a practical problem, and I'm getting messages from the organizers to close. So I'll like to thank the entire faculty and the entire experts. Thank you so much. I think we can go all night long with this, and you all made it a really interactive session. We should definitely have a part 2 of this. Thank you very much, sir, and over to the organizers.
Thank you so much, Dr. Rahul Sood sir, and all the eminent panelists for the wonderful brainstorming discussion. Like, it was incredible. Now, moving ahead, I'd like to invite Dr. Kumar Prabhas sir for the vote of thanks. So I think so sir has some technical issue. So I would like to thank all the eminent panelists and all the speakers nationally for spending the wonderful for the precious time. Thank you so much. Thank you so much, everyone. Thank you.